दे सकते हैं। तो उसके लिए आप लोग का सहयोग मिला, इसीलिए ये सब सफल।
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्म विचारसार परमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीमभयदां जाड्यान्धकारापहा। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरी बुद्धिप्रदां शारदाम्।
Hello.
Good evening, everyone. It is my great pleasure to extend a very warm welcome to all the esteemed doctors, dignitaries, and professionals gathered here today. On the occasion of NDID, the 7th International Congress on Diabetes, organized by Mahi Medical and Research Foundation in the cultural capital Jabalpur, I, Kaushiki Sharma, feel truly privileged to serve as your host for this remarkable occasion. We are deeply honored by your presence, as this conference unites some of the most brilliant minds in the medical field, providing a platform to share insights, innovation, and ideas that will help shape the future of healthcare. I would like to take a moment to appreciate the city that welcomes us with open arms, Jabalpur, often referred as the Sanskar Dhani Jabalpur, beautifully blends heritage, intellect, and nature. It is a prominent city of the Mahakaushal region of Madhya Pradesh. Historically, Jabalpur was the capital of Gondwana Kingdom, carrying a legacy of rich cultural and political significance. During the British era, it served as a major military hub, and even today it stands as an important military cantonment. Known for its arms ammunition production and storage facilities. Thus, Jabalpur is not merely a city, it is a place where tradition meets intellect, history meets progress, and culture meets resilience. Now, I would like to call our dear chairperson, Dr. Anila Day and Dr. Sheila Ghosh, I beg your pardon, to speak few words on our dear speaker, Dr. Anand Bhairani from Jabalpur, who would further speak on the topic how to manage CKD in diabetes patients. Thank you.
Sorry.
DNB nephrology, and consultant nephrologist and renal transplant physician. He's done his MBBS from Bangalore, MD from Indore, and DNB from KIMS. He's a member of the Association of Physicians of India, the Jabalpur chapter, member of the Indian Medical Association, and he has 4 publications indexed in his name, in name of journals. And he is a well-known physician. He's going to give his deliberation on management of diabetic nephropathy, which is a very, very important topic. And I would welcome you, sir, for your deliberation. Welcome.
Good evening, everyone. Thank you, ma'am, for your kind gesture. Be patient and listen to what we have to speak. So this is about the holistic approach towards treatment of the diabetes and chronic kidney disease. There's lifestyle modification, there is physical activity, there is smoking cessation, there is weight management, then there are the first line drugs, the SGLT2, metformin, RAS inhibitors, and statin therapy. The additional therapies which we are going to discuss about are the GLP-1 receptor agonist, the MRAs, the CCBs, and few of the statins and antiplatelets. So what exactly is about the nutritional intake? The protein intake should be restricted in these patients. About 0.8 grams per kg per day of protein is advised in patients who are on dialysis. Those people who are on peritoneal dialysis or hemodialysis, they are advised about 1.0 to 1.2 grams of protein intake per day. Salt intake should be less than 2 grams per day and less than 5 grams of sodium chloride per day in patients with diabetes and CKD. Smoking has effects on the reactive oxygen species, so smoking cessation is advised. Weight loss, as we all know, Mahi diabetes has been working too much on weight loss. So target of BMI 18.5 to 24.9 is advised for patients with diabetes and CKD to prevent them from progression of the CKD. The glycemic control, the guidelines for glycemic control are HbA1c monitoring has to be done at least twice a year for people who are having a good control. Those people who are having any change in therapy, at least 4 times a year, HbA1c has to be checked. HbA1c reflects average glycemia of over 3 months, but does not provide a measure of the glycemic variability or hypoglycemia. A 14 days continuous glucose monitoring and assessment of time in range and GMI can serve as a surrogate marker for HbA1c. The target of HbA1c is about 7 in our clinical practice. Cate relaxes the HbA1c guidelines for those people who are having CKD stage 5, who are not having any awareness towards the hypoglycemia, those who are having comorbidities and those who are elderly. The HbA1c is relaxed for less than 8, it should be allowed in those people. So there are various studies which have been done for management of and checking the glycemic control. The DCCC trial, the EDIC trial, and the UK PDS trial. All have showed that HbA1c reduction has proven benefit in control of diabetes. The anti-diabetic medications which we are having these days are the SGLT2 inhibitors, the sulfonylureas, metformin, GLP-1 receptor agonist, DPP-4 inhibitors, insulin, sulfonylurea, thiazolidinediones, and alpha-glucosidase inhibitors. The only 2 drugs which have shown proven benefit in stopping progression of the CKD are SGLT2 inhibitors and GLP-1 receptor agonists. The mineralocorticoid receptor agonists have also proven benefit in stopping the progression of the CKD. So metformin, we all know, we have to reduce the dose when we are using it in CKD patients. eGFR of less than 30 to 34, the dose should be reduced to 1000 milligrams per day. It is contraindicated in stage 4 and stage 5, that is below 29 ml per minute GFR. Insulin, we need to titrate and we need to avoid hypoglycemia. SGLT2 inhibitors, the few drugs, canagliflozin, dapagliflozin, empagliflozin are being used. The dapagliflozin has shown to reduce the progression of the CKD in many of the patients. The dose reduction is required in these drugs also, and it is contraindicated in stages 4 and 5. Metformin, as we all know, is the wonder drug. It suppresses the gluconeogenesis, and it is also, dose modification is also required when we are going below 45 ml per minute GFR. Metformin is contraindicated in patients who are having predisposing factors to lactic acidosis, those who are having impaired kidney function, those who are having concurrent severe liver disease, those who are having alcohol abuse, those who are having active heart failure, those who are having past history of lactic acidosis, those who are having hemodynamic instability or hypoperfusion. SGLT2 inhibitors, we have SGLT2 acts on the in diabetic kidney disease, SGLT2 reduces the progression of the disease, and this is the mechanism of action by which SGLT2 acts. The improved effects of the SGLT2 inhibitors are it reduces the hyperglycemia, reduces the hypertension, it reduces the altered tubular feedback, podocyte loss and albuminuria, obesity, inflammation, hypoxia and fibrosis. The studies which we have seen at the EMPEREG trial and the canagliflozin, the CREDENCE trial, the CANVAS trial, all these have shown positive outcomes in patients with CKD and diabetic patients. Dapagliflozin, which is the DAPA-CKD, it is a landmark trial. It is worth discussing. A randomized double-blind placebo-controlled trial which was done in 4,300 patients with eGFR of 25 to 75, out of which 7.5% people who were having diabetes. The albumin creatinine ratio was about 200 to 500 milligrams per gram. Dapagliflozin 10 grams per day was given to 50% of the patients. Out of this, the outcomes were studied. The decline in the eGFR at least 50%, end-stage renal disease, and death from the renal causes. The other composite outcomes which were studies were the hospitalization for heart failure and death from cardiovascular diseases. It was found that placebo had less effect and dapagliflozin had reduction in the primary endpoint outcomes in 9.2% and composite income outcomes about 6.6%. So incretin drugs, which we have the GLP-1 receptor agonists, and these are the drugs which are available in the market. GLP-1 receptor agonists, exenatide, liraglutide, semaglutide, which are being also used for the reduction of the dose weight these days. The dosage of semaglutide is not, no dose adjustment is recommended in patients whom we are using semaglutide. The initial dose is about 0.25 mg per week, and by any time after 4 weeks, the dose has to be titrated. The linagliptin, DPP-4 inhibitors, linagliptin, saxagliptin, sitagliptin, vildagliptin, these are the drugs in which some dose modification is required, but in linagliptin, the dose modification is not required. And it is frequently used in patients who are having CKD. Sulfonylureas, thiazidone have also been used. Sulfonylureas is a class of insulin secretagogue that stimulates the pancreatic insulin secretion by closing the K-ATP channels on beta cell plasma membranes. It's the first generation sulfonylurea that is long-lasting and are almost exclusively excreted by the kidneys. Second generation agents are short-acting and primarily metabolized by the liver. Sulfonylureas are highly protein-bound but can be displaced into circulation by other drugs, such as the metabolites of glycoside and glipizide are inert and weakly active and may be used in patients with ESRD or dialysis. So our question, which drug is to be used in sulfonylurea for CKD patients, is glycoside and glipizide. Thiazidone-diones, again, which work to increase the insulin sensitivity. It was withdrawn from the market for increased risk of myocardial infarction and high rate of bone fractures. Alpha-glucosidase inhibitors, there is inhibition of this enzyme maintains less glucose absorption and thus should be taken at the start of the meals. The other next management is BP management. Hypertension is defined as systolic blood pressure more than 130 and diastolic blood pressure of more than 80 millimeters of mercury on an average of 2 readings. Individuals with blood pressure more than 180 by 100 and cardiovascular disease could be diagnosed with hypertension on a single visit. So the goal for the AHA, ISH and ESC currently these days is to maintain a blood pressure goal of less than 130 by 80 with consistent with the drugs. The various drugs which we are using these days for the management of blood pressures are ACE inhibitors, beta blockers, calcium channel blockers, diuretics. According to the guidelines, we have to maintain BP less than 130 by 80, which can be done by using ABCD. For proteinuria patients, we are having ACE inhibitors and ARBs. The major thing which is going to happen in the renal system is the RAS activation, which has to be blocked with the help of ACE inhibitors and ARBs. This is the mechanism of RAS, renin, angiotensin, angiotensinogen 1, angiotensin 2, which leads to increased sympathetic activity. There is aldosterone synthesis. Okay. So kindly give me 2 short minutes to summarize. The renal trial and direct studies all have shown proven benefits in treating patients with renin-angiotensin blockers. These are the dosage which we can use for treatment of the patients in CKD. Azilsartan, candesartan are the new drugs which we are also using these days. Aldosterone blockade, which we have studied the MRAs, it also helps in slowing the progression of the disease. The finerenone and studies which we are doing is Fidelio and the Figaro trial, which have been shown very proven benefit in patients who are treating. Potassium has to be monitored in people who are treating with finerenone. CCBs, dual CCBs have been used. Amlodipine has shown proven benefit when we are using it. Also has low level reduction in proteinuria in patients with CKD. But majorly we have to use Nicardia or Depin when we are treating people. Addition of spironolactone is advised when we are treating people with resistant hypertension. Lipid management, management of cholesterol is very important in CKD patients, those who are having elderly lifestyle. Antithrombotic agents, those people who are having CKD, they are having more chances of developing thrombotic risk factors. For ecosprin, 75 mg can be given. And lastly, if not tolerated, clopidogrel 75 can be given. Thank you so much.
Thank you, Doctor. Thank you, Dr. Anand. You've spoken, you have covered the topic so well, and you've spoken so well. And we have great, all specialists, diabetologists, nephrologists amongst us. The house is open for discussion if anybody wants to ask something.
Sir.
Nowadays, we want MRAs. So, what is your experience like now this phenrenone compound is available, easily available. So just I want to learn what is your experience about just to restrict the proteinuria in the diabetes.
Restriction of proteinuria is important for slowing the progression of this diabetic kidney disease. As we all know, we want to stop dialysis, which is not possible. So if we cannot stop it, we should at least slow the progression of the disease. The few drugs which are available is, the latest advancement is phenrenone. The few studies which have been done is the Fidelio and the Figaro. I have seen almost more than 200 patients in the last 3-4 years who have tolerated well and with phenrenone. And we have to stop when the potassium is increasing in few patients. But mostly people are doing well on phenrenone these days. So. Anybody has any other queries?
डायबिटीज़ में जैसे हम मरीज देखते हैं तो उसमें ये पता चलता है कि कई पेशेंट तो ऐसे हैं जो 15 साल से हाई शुगर में घूम रहे हैं लेकिन उनकी किडनी खराब नहीं होती। कई पेशेंट ऐसे हैं जिनको अभी डायग्नोज हुआ है 1 साल 2 साल में उनका क्रिएटिनिन 4-5 पहुंच जाता है। व्हाट इज़ द रीज़न व्हाई देयर इज़ डिफरेंशिएशन इन द पेशेंट्स? Some patients are having chronic disease, then also they don't have any kidney damage, and some patients are having diabetes since only 4 years, 5 years, and they are having high creatinine with nephropathy.
See, everybody's tolerability is different. Some people don't show any symptoms. It is the basic status of the disease. Progression of the disease is depending. Type 1 diabetic people usually develop diabetes. 30% of the people who are having type 1 usually develop some amount of microalbuminuria and usually develop CKD. Type 2 diabetes, there is a progression towards diabetic nephropathy in the next 15 years. As we all know, progression of the disease is very important. It takes time.
So, genetics also plays the role?
Yes, definitely.
So that might be the main reason that why we are seeing the
Type 1 diabetics are mostly having genetic predisposition.
Thank you for your excellent talk. Please have a good round of applause. तालियां जो है एक एक्सरसाइज है, तो अभी हमको हैवी फूड खाना है तो एक्सरसाइज पहले से ही कर लिया जाए, तालियां रुकनी नहीं चाहिए हर लेक्चर के बाद. So अभी आओ ना. Thanks to chairpersons, please come on the stage. We will distribute the mementos. मोमेंटोज वैसे बाहर देने के लिए रखा हुआ है, पर अपन यहाँ जल्दी जल्दी कर लेते हैं, आज ज़्यादा लेक्चर नहीं है. इधर आइए. पहले सर को देना. नहीं आपको. तालियां बजती रहे, तालियां. थैंक यू मैडम. यहाँ देखिए मैडम. Thank you. Talk. Over to you, madam.
Rani. Next, moving on, I would like to call our dear chairperson, Dr. Karnan P.N. Gupta and Dr. Ajay Karoskar.
Ajay Kaduskar from Nagpur.
Dr. Ajay Karoskar from Nagpur. I request to... Also, I would like to request our speaker, respected Professor Dr. V.K. Bharadwaj from Jabalpur, who will further speak on the topic why obesity is chronic disease. I request our moderator to introduce Professor Dr. V.K. Bharadwaj.
Professor Dr. V.K. Bharadwaj does not need any introduction at least in the city of the Jabalpur. He is a well-known personality. He is a stalwart in the field of endocrinology and the medicine. So I'll just not wasting any time. I'll just ask. I'll request Professor Bharadwaj to please start his talk.
And just to add on to what he said, just as Dr. Bharadwaj sir doesn't need any introduction in Jabalpur, he doesn't need any introduction in Nagpur as well. So over to you, Bharadwaj.
मैंने पहले
Good evening, dear friends. At the outset, I would like to thank the organizers for giving an opportunity for interaction with fellow colleagues. Thank you, Dr. Gupta sir and Dr. Kaduskar sir, for kind words of introduction. I shall be talking about rise of GIP from biology to medicine. This is a with parenteral administration of nutrients. So these are the factors which enhance endogenous secretion of insulin in response to nutrient intake. This was known since 1920s. But the first GI incretin molecule to be identified was GIP, which was discovered in 70s, secreted by duodenal K cells and in response to glucose and lipids. GLP-1 was discovered a little later. It is secreted by distal ileal cells and stimulant is glucose. So nutrient load in the gut stimulates release of GIP and GLP-1, which are carried throughout the body, and they act on beta cells and alpha cells, the twin defects in type 2 diabetes. They bring about glucose-dependent increase in insulin secretion and glucose-dependent glucagon suppression. So, until advent of incretin-based therapy, the emphasis was on beta cell stimulation. Nobody looked at role of alpha cells. But the twin defect is now being addressed by use of the two incretin agonists. The earlier research was mainly focused on GLP-1. GIP was ignored. But later research found that incretin effect is 2/3 contributed by GIP and 1/3 is the contribution of GLP-1. So the difference between insulin secretory response to an IV load versus an oral administration is the incretin effect. They are responsible for majority of insulin release following a nutrient ingestion. In 80s, Newek et al. Did the studies in healthy subjects and patients with type 2 diabetes, and they discovered blunting of incretin response. So incretin effect is there and it is blunted in type 2 diabetics. So incretin-based therapies can help in increasing endogenous insulin secretion, and the two molecules act synergistically. They bind on receptors present on beta cells and alpha cells and mediate their action through post-receptor mechanism. This is a study which looked at insulin response to glucose plus GIP, glucose plus GLP, and glucose plus both. The open circle says glucose-related release of insulin. The inverted triangles is glucose release in response to infusion of GIP, and the yellow line is for GLP-1. The green line is response of insulin to infusion of both GIP and GLP. So, in this isoglycemic plasma glucose study, GLP and GIP together produce a synergistic response. So this shows the mechanism by which insulin secretion is enhanced. Once the depolarization of beta cell takes place, there is opening of voltage-gated calcium channels. Calcium enters into the system, into the cell, and causes release of insulin. In presence of GLP-1 and GIP, these are G protein coupled receptors which activate CAMP. This CAMP activates protein kinase A and augments the glucose mediated insulin secretion. So GIP and GLP-1, they are not initiators of insulin secretions. They would not act on their own. They are augmenters of insulin secretion which is initiated by glucose. So they come under the category of potentiators. Sulfonylureas come under the category of initiators. Coming to relative contribution of the two molecules. This is the isoglycemic situation is achieved in two sets of individuals, one on oral glucose administration, other one on intravenous glucose administration. The blue line is the response to GLP-1 infusion. And the indigo line in the lower part of the slide is response to GIP. So So out of total incretin effect, GIP contributes 2/3, and 1/3 is the contribution of GLP-1. So by utilizing both the molecules, both the actions, GLP-1 agonism and GIP agonism, we can increase the incretin effect. So substrate absorption leads to glucose release, which accounts for 33% of the release in response to glucose, in response to nutrient absorption. GLP-1 contributes 22% and GIP contributes 44%. So endogenous GIP generates a more significant effect on insulin-mediated glucose clearance. Coming to distribution of GIP receptors, it is present in the adipose tissue and in the endocrine cells and endocrine pancreas, both alpha cells and beta cells. Of relevance to present context is the presence of GIP receptors on adipose tissue. Additionally, there is a differential effect of GIP on glucagon secretion. GLP inhibits glucagon, but GIP increases glucagon. And that way, it helps in maintaining euglycemia without increasing the risk of hypoglycemia. Activation of GIP receptors present on adipose cells enhances insulin sensitivity in the adipose tissue, may improve functional status of adipocytes. There is impaired nutritional partitioning in type 2 diabetics, and that may be improved by use of GLP-1 and GLP-2 agonists. These are the 4 set of observations. One is administration of saline. Second is administration of GIP. Third is administration of GLP and saline. And fourth is high glucose, high insulin with GIP. The third situation leads to increased blood flow through the adipose tissue. Increased blood flow leads to improvement in lipid metabolism related endpoints. So hyperinsulinemia, hyperglycemia with GIP increases blood flow through the adipose tissue, improves glucose uptake, improves free fatty acid re-esterification. So there is increase in triacyl glycerol hydrolysis, indicating improved fat utilization. Glycerol output is decreased. The shaded bar, shaded red bar, glucose uptake is increased and free fatty acid output is reduced. This indicates improvement of fat utilization, decrease in free fatty acids which are atherogenic and insulin antagonizing, decrease in blood glucose, and increase in free fatty acid esterification. So net effect is improvement in lipid parameters, but there is a possibility of increase in subcutaneous white fat that can be ameliorated by appropriate calorie balance. So enhanced insulin release in response to oral glucose as compared to intravenous glucose is known as the incretin effect. This is mediated by 2 incretin molecules, GLP-1 and GIP. GLP-1 accounts for 1/3 of the incretin effect. 2/3 is contributed by GIP. It is mediated through receptors present on beta cells, which are G protein coupled receptors with a potentiation of CAMP, which augments glucose-mediated insulin release. Adipose cells take up lipid, increase storage capacity at the level of subcutaneous fat. So there is a possibility of weight gain which can be ameliorated by maintaining energy balance. In summary, GLP-1 acts on brain to cause reduced food intake and increased satiety, while GIP causes reduced appetite, reduced food intake. Subcutaneous white adipose tissue does not have GLP-1 receptors. GIP receptors mediate improvement in insulin sensitivity in adipose tissue, increase in buffering capacity, and increase storage capacity in the subcutaneous compartment. At the level of pancreas, both increase insulin secretion. Glucagon is inhibited by GLP-1, stimulated by GIP. At the level of stomach, it is only the GLP-1 which decreases motility. So these are the complementary mode of actions which can be utilized for better management of weight and better management of glycemic targets. Thank you.
Thank you, sir, for walking us through a difficult topic and making it easy for everyone. Any questions, queries, comments from the audience?
Thank you so much, Bhardwaj sir, for the excellent presentation as always. Now I request chairpersons to kindly facilitate our speakers and kindly come to the stage, please. I request our chairpersons to kindly facilitate our speaker, Dr. B.K. Bhardwaj sir. Big round of applause, please. Now I request Bhardwaj sir to kindly hand over the mementos to our chairperson, Dr. Gupta and Dr. Ajay. Now we move on with our next session.
I request our next chairperson, Dr. M.L. Jangir, sir, to speak few words on
I request Dr. Ajay to speak on one of the very important topics, that is Surpass 2, how is tirzepatide superior to a GLP-1 receptor analog? And this chairperson for this talk will be Dr. M.L. Jangir sir and Dr. Rajkumar Jain sir. I request our chairpersons to kindly introduce our speaker, who is from Nagpur, Dr. Ajay Kaduskar sir. CV slide, please. Our chairpersons to kindly give a brief introduction of our speaker.
हेलो मैं डॉक्टर जहांगीर फ्रॉम मदन महल जबलपुर.
Dr. Ajay Kaduskar has done MBBS from GMC Nagpur, MD Medicine, LTMMC, Sion Hospital Mumbai, fellowship in European Asian Academy of Clinical Lab. He is diabetic metabolic consultant. Scope certified obesity management, completed AL for healthcare programs in Singapore, director Nirama Diabetes and Heart Care Nagpur, president Diabetic Association Nagpur, chairman Association of Physicians of India, with her joint organizing secretary, MAPCON 2023. He is president of Dr. V.S. Kaduskar Memorial Foundation, vast experience in treating type 2 and type 1 diabetes, thyroid, obesity, gestational diabetes and metabolic diabetes. His area of interest is type 2 diabetes and preventive cardiology. Speaker at various academic forums and publications in Index Journal. I request Dr. Kaduskar to please deliver.
Thank you, sir. It's always a pleasure to be at Jabalpur, and thank you, Ashish Bhai and team NDID for having me here once again. At the outset, why are we here discussing about GLP-1 receptor analogs? The reason is, like, I see many senior faces here. Treatment of diabetes has undergone a sea change. Understanding of diabetes has undergone a sea change. And with the better understanding of the pathophysiology of diabetes, we have now therapies which target the pathophysiology involved in treatment of diabetes. And obesity happens to be one of the important targets of treatment of diabetes in today's era. While maybe the past decade was of SGLT2 inhibitors, the present decade is going to be of GLP-1 receptor analogs. Before I begin, I would like to just ask a question to the audience. How many of you look towards obesity as a disease? Good. And how many of you write obesity or type obesity in your prescriptions? Great. It's a good thing. We need to have a paradigm shift in the way we look towards diabetes or towards obesity in our day-to-day clinical practice. Most of the part of my talk has been done by Bharadwaj sir. He has walked us through the incretin defect, the role of GLP and GIP in management of diabetes, what's the physiology and what is the pathophysiology and how do we deal with it. I'll be focusing more on tirzepatide, which is a dual GIP-GLP-1 receptor analogs. Like all classes of molecules for treatment of diabetes, be it DPP-4 inhibitors, SGLT2 inhibitors, similarly for GLP-1 receptor analogs, in today's times we are spoiled for choices. So as a clinician, we need to make the right choice on Monday when we go into our clinics and decide to use these class of molecules. So I would be trying to just elaborate upon how we can extrapolate the findings of various clinical studies in our day-to-day clinical practice. It's a part of the Eli Lilly sponsored symposium, hence this disclosure slide. The incretin effect or the incretin defect which sir talked about, it's not a new concept. The incretin term was coined somewhere around 1930 and 1932 by Jean Labarre, just because when they were investigating about the function of pancreas, the term secretin, which we learned in physiology in first MBBS, was for the hormone secreted by the gut, which cause secretion from the exocrine pancreas. Similarly, for the hormone secreted from the gut, which cause insulin release from the pancreas, the term incretin was coined. And like sir said, it is a potentiator of insulin secretion. It is not the initiator, but it is a potentiation of insulin secretion because it causes an incremental, I think the pointer is not working on the LED screen, but anyways, you can have a look at it. It causes an increase in the insulin secretion in response to oral glucose and not in response to IV glucose. That's the reason that it is a potentiator, and incretins, they are responsible for majority of the insulin that is released. If you look into how much of insulin is released in response to substrate absorption, it is 33%. But when it is the insulin that is secreted in response to ingested glucose is 66%, and out of this 66%, 2/3 of the insulin secretion is contributed by GIP. While we had many GLP-1 analogs for the past 20 years or so for the treatment, but a dual GIP the present is, it is glucose dependent insulinotropic polypeptide. Earlier it was gastric inhibitory polypeptide. The nomenclature has undergone a change with the better understanding of the molecule. It was discovered in fact earlier as compared to GLP-1, which is secreted from the distal ileal cells, whereas the GIP is secreted from the duodenal case cells. This slide was shared by Sir. What is important is that the GLP-1 activity and the GIP activity, they complement each other. Hence, there is an added advantage of having a dual analog, dual GIP and a GLP analog. For example, GLP-1 activity causes increased nausea, which is compensated to an extent by GIP activity, which decreases nausea. GLP-1 activity causes reduced glucagon secretion, whereas GIP activity increases glucagon in a glucose dependent way. So if a person has hypoglycemia, the glucagon secretion increases, but if the patient is in a hyperglycemic state, the glucagon secretion goes down. Probably that's the reason that these class of molecules have less incidence of hypoglycemia. And additionally, again which Sir talked about, GIP has an additional activity on the adipose tissue, which has got its own advantages in the form that it prevents ectopic fat deposition, which is what we are targeting in today's time. I think we have a lecture on MASLD as well, where we would be talking about ectopic fat deposition. Another advantage of this activity of on the GIP hormone is that it helps in reducing the it helps in improving the insulin sensitivity because of the increased blood flow in the adipose tissue. This is what I had mentioned earlier about, that 2/3 of the incretin effect is contributed by GIP, and that's the advantage of having a dual analog over a single analog. So coming to the molecule which we are discussing, that is tirzepatide. What is tirzepatide? Before I begin, how many of us are using tirzepatide here? Well, then we need to know about it. It's a dual GIP and GLP-1 analog. Out of this, the activity on the GIP receptor is similar to native GIP hormone, so it has a bias towards GIP, whereas the activity on the GLP-1 receptor is lower as compared to the native GLP-1. It is a 39 amino acid peptide. That's the reason that it is available in an injectable form. And there is a side fatty chain moiety at C20 position, which helps in its binding to albumin, and that's the reason that its half-life is of around 5 days, which helps in having a once-a-week dosing. This once-a-week dosing in day-to-day clinical practice helps in improving compliance of the patient. This is what I can tell you. Important thing, no dose adjustment is required in renally compromised patients. Even in ESRD stage, it has been used, although it has been less studied in ESKD patients. But then, point to be remembered here is that no dose adjustment is needed with renally compromised patient. With mild hepatic impairment also, it can be used. In severe hepatic impairment, as with all anti-diabetic molecules, it is to be used with caution. The mechanism of action of tirzepatide is similar to the GIP analog, which Sir talked about. On the central nervous system, it decreases appetite and decreases food intake. In the liver, it decreases fat content. So it has got a role to play. All GLP-1 analogs also have got a role to play in MASLD, where we are short of molecules for treatment. At the level of pancreas, it increases insulin secretion, decreases glucagon, decreases gastric emptying, and increases insulin sensitivity, which we had already discussed till now. Coming to the evidence with tirzepatide, the SURPASS was a phase 3 trial which looked into the glycemic efficacy of tirzepatide as a molecule, whereas the SURMOUNT studies looked into the weight management potential of tirzepatide. And as in clinical practice, what is the use of all these clinical trials is that we can try to extrapolate the findings of these trials in our day-to-day clinical practice, in which subset of patients, which set of patients we can use the molecule and how we can use the molecule. It has been studied as a monotherapy in comparison with placebo. Most importantly, the SURPASS-2 compared tirzepatide with semaglutide, which is the other GLP-1 RA available in the market. It has been compared with digludec on the background of metformin SGLT2 therapy, with glargine on the background of SGLT2 SU and metformin therapy, and again in combination with insulin. So in a nutshell, it has been studied in all permutations and combinations, the way we use our anti-diabetic molecules in our day-to-day clinical practice. So coming to the topic of interest which everyone wants to know about, how do tirzepatide and semaglutide fare in a head-to-head comparison? Tirzepatide 5, 10 and 15 mg has been compared with injectable semaglutide 1 mg as an add-on to metformin in a 1:1:1:1 study, which was randomized double-blind trial. The 3 arms received either 5 mg, 7.5 mg, 5 mg, 7.5 mg, 10 mg or 1 mg of semaglutide. And what was the results were that even the lowest maintenance dose of tirzepatide, that is 5 mg, mind you the highest dose is 15 mg, you initiate with 2.5 and gradually up titrate by 2.5 mg every 4 weeks. 5 mg demonstrated superior A1C reduction vis-a-vis semaglutide 1 mg. Was it statistically significant? No. But 15 mg or 10 mg showed statistically significant A1C reduction as compared to 1 mg of semaglutide. It's a costly molecule. So the common question that is asked by patients, kitne jaldi benefit milega? The answer is weeks, and it's a sustained benefit through weeks 40. That was the study duration of the trial. And how many patients achieve A1C target, which is what we are interested in knowing about, is that with around 5 mg, if your target is less than 7, around 86% of the patients achieve their target HbA1c of less than 7. And if you, here lies in the potential of these class of molecules, is that with significant weight loss, you can target diabetes remission as well. So if your target is less than 5.7, with a 15 mg dose, around half of the patients achieve this target of less than A1C of 5.7. Coming to the weight gain part or the weight loss part, even tirzepatide 5 mg demonstrated superior weight reduction versus semaglutide 1 mg. Mind you, the comparison was with semaglutide 1 mg and not with semaglutide 2.4 mg. So 5 mg also demonstrated, and if you compare it with 15 mg, of course, the higher the dose, the greater is the weight reduction with tirzepatide. This is what we need to keep into mind. And does it plateau? The study duration was to the 40 weeks. What happens after 40 weeks? We will come to know when we start using it beyond 40 weeks. It's now just 6 months that we have been using this molecule. The upper line is of semaglutide and the lower 3 are of 5, 10 and 15 mg of tirzepatide. As you can see across the board, when compared with 1 mg of semaglutide, tirzepatide showed a benefit. Talking of the composite endpoint of A1C 6.5, weight loss more than 10% without any clinical significant hypoglycemia. This is what we want to achieve in each and every patient. This is our dream of having our, for each and every person with diabetes. Well, tirzepatide 15 mg achieved these composite endpoint in around 60% of the patients. And if you don't want to increase the dose, if you want to have just end at 5 mg or 10 mg, at 10 mg also around half of the patients achieve this composite endpoints of A1C less than 6.5, weight loss more than 10% without the risk of hypoglycemia. Talking of the side effects, the side effect profile of tirzepatide and semaglutide was similar. One point I would like to highlight, and which you all must have experienced, is that the incidence of diarrhea is significant. For anything which delays gastric emptying, you won't expect diarrhea. But diarrhea does occur. You need to adjust your dose as per the patient's schedule. The diarrhea occurs because change in the gut microbiota, which occurs with the usage of these molecules, and the food that is that goes forward in the intestine, the quality is different than that because of the delayed gastric emptying. These are some of the postulated mechanisms why these class of molecules cause diarrhea. The hypoglycemia risk is less, but yes, if you are using it as an add-on to insulin and sulfonylurea, you need to titrate the dose. So, in a nutshell, it's a dual GLP and GIP-1 receptor agonist, which has shown a good A1C reduction, even at the lowest maintenance dose of 5 mg, and has shown a significant weight reduction at all doses, the greatest benefit being seen with 15 mg. The safety profile is similar to the other GLP-1 receptor analogs. If some questions are there, we can have a good discussion on it. Thank you very much. Thank you, sir.
Thank you, sir. Thank you, Dr. Ajay Khadoskar, sir. I request our chairperson to facilitate our speaker
Sir wants to have a comment.
on the
Bharadwaj
stage
sir
now.
wants to have a comment.
Bharadwaj sir.
Blindness, if 90% of patients have GI disturbance on Monzaro.
Yes, sir. Sorry.
Double blindness can be, how can it be maintained when 90% of patients on Monzaro develop?
Sir, actually that trial had some fault. Like it was a 1:1:1 study.
But it becomes
Yes.
an open label once the patient...
After some weeks, it was an open label study. It was not double blind throughout the course of the study. After a certain period of time, it was an open label study.
Say it is versus placebo, sir,
Yes,
class 1
yes,
versus
yes.
placebo. After 4 weeks, you realize that this person is on Monzaro, this person is on placebo.
Placebo, it
Double
happens.
blindness cannot be
All those who are doing studies, they get to know, they have some inkling that whether this patient is in the placebo arm or in the study arm.
थैंक यू अजय. ये जो लेक्चर था, ये नई दवाई जो आई है मोंजेरो, इससे वजन कम होता है, शुगर कंट्रोल होती है. ये इतने चमत्कारिक दवाई है. पेशेंट मैंने पहली बार देखा है जो इतनी महंगी दवाई खुद आके बोलता है कि हमको लगा दो. मतलब आज तक हमारी प्रैक्टिस में ये नहीं हुआ कि महंगी दवाई है उसके बाद पेशेंट खुद लेके आ रहा है कि हमको चालू करना है. तो इतने इसका वेट रिडक्शन, व्हाट इज योर एक्सपीरियंस इन वेट रिडक्शन?
Weight reduction is great, and one point that I would like to make, that you need to up titrate the dose.
Yes.
That up titration is very, very essential. What happens, like many a times I've seen that patients tend to stop at 5 mg, 7.5 mg, but then I think you should up titrate at least up to 10 mg to get tangible results. You need to, patient counseling is very, very important about the side effects. With any GI side effects, the first thing that the patient wants to do is to stop the medicine, but you have to tell the patient that ये ऐसे GI side effects नहीं हुए तो दवाई काम ही नहीं करेगी. And secondly, that tell the patients that you have to be patient, don't expect quick fire results. It's not something that आप 2 महीना पैसा खर्च कर दो, आपको पूरा जादू की पुड़िया नहीं है. Last week itself, I had a patient who said, बेटी की शादी है next month, मेरे को मोंजारो दे दो.
That is, these are the patients coming. One military woman came and she want to go to some Congo. She has been selected for Congo, but the weight requirement was 62 and she was 75. She has attained 62 with Monjaro in 3 months. So it is a wonderful drug, but if you are tolerating well, then it is a very wonderful. But I want to ask to Bharadwaj sir, how long we should take it, then it is having sustained effect. मतलब कितने महीने के बाद हम छोड़ सकते?
नहीं छोड़ सकते. I think data is available up to 2 years.
Yes.
So 2 years it can be used.
It's $1 million question. कब छोड़ सकते हैं? Ideally, you have to take it lifelong. Since obesity is a chronic disease like diabetes, hypertension, you need therapy for it also lifelong. But even in the US, around 50% of the patients tend to stop it.
Sir.
Is it fair to compare 1 mg semaglutide with this drug?
No.
So this trial has the flaws.
Because, see, 1 mg is the, like it's the Ozempic thing which is there. And the maximum dose which
comparing the Ozempic is the anti-diabetic drug.
it is an anti-diabetic drug.
When you
It is
compare
an anti-diabetic
versus
drug.
obesity, you have
But the study, my point was to highlight the SURPASS-2 trial which has been conducted, and many a times what happens in clinical practice, 15 mg of tirzepatide is also not used. So 10 mg, and even we have got patients taking Wegovy as well. So very few patients reach up to 2.4 mg of Wegovy. Majority stop at 1.7. This is what I've seen with Wegovy as well. And
Okay.
similarly with Mounjaro, majority of the patients stop at 10 mg instead of 15 mg.
Sir, I would like to have one question. In your clinical experience, what is the, like, it is 1:1 with the Mounjaro, GI side effects with Mounjaro versus Wegovy?
1 mg of semaglutide with 2.5, 5 and 10 mg, 5, 10 and 15 mg of tirzepatide.
Same. Sir, I had one patient who was on Mounjaro. He lost 25 kg in last 6 months, I would say. But he now recently developed thyrotoxicosis. Is there any relation of Mounjaro?
Medullary carcinoma of thyroid is a strict contraindication.
No, there was no past history, sir. He recently developed, after taking 4 to 5 months of Mounjaro, he developed thyrotoxicosis.
You need to investigate him. Why has he developed thyrotoxicosis?
He has just recently landed up 2-3 days back. So
Sagar, this case
Yes, it's
to the medical
you
team.
should be
Yes,
reporting
I got
it.
one patient with thyrotoxicosis.
You should be reporting
yeah.
it. It's a very, very rare phenomena even to have a medullary carcinoma of thyroid. And other thing is that you need to investigate why that person,
I am
that
doing that,
patient has developed thyrotoxicosis.
And any other side effect you have seen apart from GI side effect?
GI side effects predominate. One patient had some depressive pancreatitis is something which we need to think about. But again, if the patient has past history of pancreatitis, you might use them with caution. If the patient develops pancreatitis on Mounjaro, don't restart it. One patient had some psychiatric complications, although they are not seen as they were seen with the earlier anti-obesity medications like rimonabant, etc., which were withdrawn because of the depressive symptoms. So since these molecules again act at the level of the nuclear segments and at the level of the hypothalamus, that is, but I had sent him to the psychiatrist, but he said that he has more of anxiety and less of depressive symptoms.
AKI,
so I continue.
acute kidney injury?
Acute kidney injury is a cause of concern, especially while they say that you can use it up to ESKD, but because of the nausea vomiting potential, if a patient who is already renally compromised develops any form of gastroenteritis, by either gastritis or gastroenteritis, the chances of precipitation of AKI are there. Again, one more thing is about diabetic retinopathy.
Yes.
That's a gray area, whether it causes worsening of diabetic retinopathy or diabetic macular edema.
Neuritis, optic neuritis
NAION, NION that you are talking about.
That is also
a cause of concern, but then there is no cause and effect relationship could be established between any GLP-1 therapy and NION. I have one ophthalmologist patient who refuses to take this just because of that. But as of now, there is no black box warning for the use about NION with this group of molecules.
तो कोई भी चीज चमत्कारिक नहीं होती है, उसका साइड इफेक्ट होता है, तो आपको खुद से पहले करना है. ठीक है, जिसका नहीं हो रहा है तो then Mounjaro is the best drug at present in the scenario for weight loss. Diabetes control is excellent with that because it reduces the body weight and insulin resistance. ये 2.5 मिलीग्राम से शुरू होती है हफ्ते में एक बार, फिर 5 मिलीग्राम अगले 4 हफ्ते, उसके बाद फिर 7.5, फिर 10, ऐसे बढ़ाना पड़ता है gradually every 4 weeks. Yes sir, आपका कोई question?
Are developing, you have told about pancreatitis, but many of the patients, my patients are developing asymptomatic hyperamylesemia.
Yes, sir.
Yeah.
So you are absolutely right.
If what is to be done at that
if
time?
it is asymptomatic hyperamylesemia or hyperlipidemia, you need not worry. It is not pancreatitis.
Yes.
You need, if pancreatitis is there, then it's a cause of concern. Just because elevated amylase is there, you need not worry.
Because it is approximately those patients are having amylase level around 200 to 250.
Absolutely. So that is not a cause of worry. Even in the trial, some patients had that. And about the diarrhea part, it occurs a few days immediately after the giving of dose. So you can adjust the day of the dose as per the patient's schedule. Like those who have a weekend off, Saturday and Sunday off, you can give it on the Friday so that by the time the patient joins his duties on Monday, the diarrhea effect goes on. Beforehand, what happens if a patient misses the dose? Many a time patients are traveling. If he is taking it on every Sunday, if he misses the dose for the next 3 days, he can take it. He can take it till Wednesday. If his normal dosing schedule is on Sunday. But if he doesn't take it by Wednesday, it is better to skip that dose and take the next dose. Don't take 2 doses. Our patients think much ahead of us. So I had one patient who missed the dose and said that इतनी महंगी दवाई है इसलिए मैंने 2 dose लगा लिए next Sunday को. This shouldn't happen.
Hello. So we are having with us a renowned Dr. Jayant Panda from Odisha, Bhubaneswar, from the city of Puri, Jagannath Puri, and we should give him a big round of applause. He want to share some Odisha story for the Monjaro.
I was there in the discussion, very well presented, very well discussed also, interaction was very good. Personally, I have more than 200 patients now on Monjaro. We started much before Monjaro was launched in India. They got it from Abu Dhabi and Dubai. And then, you see, people are so keen, एक social media craze हो जाता है, तो ये लोग डॉक्टर को बोलते हैं आप जहाँ से भी लाके मेरे को दो. तो मैं बंसी भाई को पूछा कि आप क्या कर रहे हैं, तो वो बोला मंगवाओ, पेशेंट चाहता है तो मंगवाओ, क्या प्रॉब्लम है. And there are many people relation, they coordinated, and you know, when initially it was launched, it was not complete. वो सीरीज देते थे, मल्टी डोज वायल देते थे, there were so many things not very acceptable. अभी पेन आ गया. And then regarding the follow up, average patient 5 को respond कर गए. Remember 2.5, 7.5, 12.5, they are not therapeutic doses, they are step up doses. We start with 2.5, go to 5, then 7.5, then 10. Don't keep longer with 2.5, 7.5, 12.5. The therapeutic doses are 5, 10 and 15. And then these are all step up doses. And ये भी होता है कि आप 10 पहुंच गए, तो many people tell sir नहीं होता है, उल्टी होता है, distension होता है, they don't tolerate well. They want to come back to 7.5, but we don't have literature recommending them to continue in 7.5. मैं बोलता हूँ कि आप 5 में कुछ दिन रह जाओ, for now, because 7.5 is a step up dose. That is number 1. Number 2, आपको बहुत careful रहना है कि कहीं patient DPP-4 तो नहीं खा रहा है. We see, yeah, that is miss. You see, ये दोनों incretin group का drug है. You need not combine GLP-1 agonist with DPP-4 inhibitors. ये क्या है कि वो नज़र में नहीं आता है, और कोई है वो पहले खा रहे हैं तो खा रहे हैं. And in many combinations now with sulfonylurea, with metformin, with pioglitazone, there is DPP-4. If you are not noted that, many are on DPP-4 and GLP-1 both, and that is a cause for all these things. Pancreatitis, the retinal issues, the thyroid issues, ये सारे जो है आपको careful रहना, carefully prescription देखो, DPP-4 को हटाओ. Those who are on tirzepatide or semaglutide, आप DPP-4 को हटाओ. That is number 1. Number 2, if they are not tolerating, I have seen diarrhea also. Not only distension and vomiting, we have seen loose motion also. एक patient का तो इतना headache हुआ, intractable headache, we had to stop. 4 दिन में they developed intractable headache. But overall, sir जैसे दिखाया, it's a septic profile is very good, and we have got in an average 15 kilo loss in 3 months time. 15 kilo. That's a good loss. And regarding the question of कितना दिन खाना है, अभी तो आपको continue करना है. Don't tell that lifelong, that inhibits the patient. ये बताओ कि आपको अभी लेना है. We cannot tell. I hardly find few people who are so motivated to continue the drug or continue lifestyle and diet aggressively to maintain the weight. And it has been proved adequately that lifestyle, diet, exercise में आपका weight maintenance नहीं होगा. तो fat, lean, then fat. That is the natural story. तो आपको बोलना है कि आपको lifestyle के साथ दवा ही लेना है. अब क्या ले रहे हैं? Then now I will tell or will tell in future. But now in comparing to Wegovy also, there is a question regarding 1. May not be 1, maybe 1.7, maybe 2.4. But comparing to Wegovy is the drug with cardiovascular safety, which is proved beyond doubt. CV safety में जो GLP का सबसे अच्छा वर्कअप हुआ है, एविडेंस मिला है, वो Wegovy का है. That is only semaglutide in a higher dose. Ozempic is the lower dose, and we don't have recommendation for weight management. Ozempic is for diabetes management only. That is still not available in India. Shortly it will be available. But remember 2.5, 5, 1 hai only for diabetes. Like SGLT2 inhibitor, along with diabetes, you may have little reduction of the weight. But weight management dose is Wegovy, where you can go up to 2.4. 1.7 and 2.4 are the average drug, but they are not matched Mounjaro. My experience is they are not matched Mounjaro. And there are many head-to-head trials. You also heard that, and that's why patient लोग भी बोल रहे हैं कि sir वो जो दूसरा दवा ठीक था, my friend is taking that and having a good loss. Why don't you give me Mounjaro? Why to continue in Wegovy? So just you have to be careful about these few things. The retinal involvement at presentation, the history of thyroid disorders, pancreatitis, of course, is not a contraindication. You have to keep a watch. No need monitoring very frequently. I see many physicians do amylase, lipase, CT scan every month, every quarter. Not required. Just ask about the dyspepsia and the GI side effects. Perfectly well tolerated drug. And because we are using before the launching of the drug, and in Odisha, Dr. Niroj Mishra and me were first initiated into training, and then we had a program in Bhubaneswar also recently regarding the program. Actually, the fact is, when it becomes a head-to-head, दो चीज सामने आमने आ जाते हैं तो फिर that could not stood the market. We could not stood the market. That was the situation where, you know, there is a big debacle at the Novo Nordisk, shacking people also. But Mounjaro, it's a clean next.
Novo Nordisk के बंदे भी यहाँ पे हैं.
I know. I am part of the both team. We have done the phase 4 trial also. But thing is that I tell for cardiovascular safety we have clear. Those who have a clear CAD or the cardiovascular illness, you can prefer that. But regarding the weight reduction, because it's genuine, GLP, GIP dono hai. Arvind and Bitul will agree to me. They have bigger experience than me because they have fattier people than Odisha. Odisha is a poor state and many people are lean. We are known for lean diabetes and marasmic people and low birth weight babies. But the rich people are here. He will tell his experience better. Thank you.
Yes. So, come. So, ये कुछ ज़्यादा ही खिंच गया नई दवाई के ऊपर क्योंकि जानकारी सर की बहुत ज़्यादा एक्सपीरियंस था तो इसीलिए उनको यहाँ बताने के लिए आप लोगों को दिया कि हर दवाई का साइड इफ़ेक्ट भी होता है, पॉजिटिव इफेक्ट भी होता है. तो आपको प्रोज एंड कॉन्स देख के किस मरीज में लिखना है वो आपको देखना चाहिए. प्लीज़ कम फॉर फेलिसिटेशन चेयरपर्सन्स, रिस्पेक्टेड चेयरपर्सन्स. स्पीकर. तालियां बजती रहें. सर वहाँ देखो. थैंक यू. नाउ यू विल गिव. Kaduskar sir will give to our chairperson, respected Rajkumar Jain sir. तालियां बजती रहें. आइए. तालियां रुक जा रही हैं. Thank you. आइए, we will move on to the next topic. Over to you, madam. Fast. सबको भूख लग रही है. क्या है किसका है?
Moving on to our next session by Dr. Priyanka Kukreli, who would now speak on the topic test to screen complication in T2DM. I request our chairperson, Dr. Prashant Punekar, Dr. Mohan Lalwani, and Dr. D.S. Behrani, and Dr. Rishikant Ahirwar. Sir.
So I'll move on with my presentation. Yeah.
Dr. Priyanka Kukreli is the associate professor in the Jabalpur Medical College. She is very well experienced diabetologist. She will dwell upon the how to test the complications in type 2 diabetes.
Thank you, respected sir. Good evening, everyone, and welcome to NDID Jabalpur. So the topic, 4 days back, Dr. Dengra called me that you have to give a talk on select your topic, and I thought most of the topics are already covered. So I just took this simple, very easy to take a few simple tips and trips I'll be talking about. How to go for complication screening in newly diagnosed type 2 diabetes patient. So our patient, we have diagnosed our patient with the clinical diagnosis. It is type 2 diabetes, okay? So earlier we used to talk about glucocentric approach. What is glucocentric? HbA1c has to be less than 7%, and we only target those things. And now in 2025, I would say it is an organocentric approach. We got to work on each and every organ and save the complications of our type 2 diabetic patient. So as I have written, we have to shift our mindset from glucocentric to organocentric approach. So just start the treatment. Yes, we have to definitely start the treatment, but remember to screen all our type 2 diabetic patient, as ADA also says, at the first visit of our patient only, we have to give the test to the patient and screen all the patient for complications. So is it important to screen all two? Yes, definitely it is important. As I will talk about some researches, the researches says that the newly diagnosed patient, 6.1% has retinopathy. I would say this is more, this will be more. Even I have done studies, retinopathy is found to be more than this. 13.1% neuropathy was detected at the time of diagnosis, and distal symmetrical peripheral neuropathy was also detected to be 10 to 15% on newly diagnosed type 2 diabetic patient as per ADA. In 2021 retrospective study, they also say that only few, like 37% of patients are only screened for CKD in their first year of getting diagnosis. So because of this, we miss the early albuminuria stage of our patient, where we can slow the progression of CKD, as talked by Dr. Anand Behrani. So fatty liver also we have to screen, so that we can prevent NASH and finally hepatitis stage in our patient. And it has been seen that 45 to 72% also had NASH. And the prevalence of significant coronary artery disease in individuals with newly diagnosed type 2 diabetes is substantial, which is ranging from 15 to 40%. So definitely cardiac diseases also we have to screen in all our patients. So how we have to work on the investigation? So as we all know, these are the microvascular complications of diabetes, that is retinopathy, neuropathy, nephropathy, macrovascular complication, coronary artery disease, cerebrovascular diseases, peripheral arterial disease. So we have to screen to prevent all these diseases complication in type 2 diabetic patient. So first of all, which test we have to advise? We all know the opening investigation in all our patient has to be CBC. So in CBC, what we have to look for? Primarily hemoglobin, as hemoglobin will tell us about the chronic illness or the early phase of CKD we can diagnose with hematocrites. MCV, when MCV is high, low, we can make diagnosis. If MCV is high, we have to go for vitamin B12 deficiency, which has again association seen with metformin. So we can have correlation with that. Patient is in sepsis or not, we can have that. If we talk about nephropathy, renal functions test we have to go for urine, routine microscopy, and one of the very important tests I would advise in all our newly diagnosed type 2 patient is USER, that is urine albumin creatinine ratio we have to advise, so that we can detect the patient at an earlier stage. When the creatinine level rises, already 70% of our kidney has been damaged by that time. So we have to detect early, we have to look for USER. So less than 30, normal, 30 to 300 microalbuminuria, greater than 300 macroalbuminuria. As we have talked about, there are new drugs now, MRAs, which is Finrenon, which can prevent this microalbuminuria and prevent the progression of our patient landing up into CKD. So renal function test, definitely urea creatinine, and we have to calculate eGFR of all our patients, which is one of the important aspects of our newly diagnosed type 2, so that we can work accordingly with our OHAs also. That is important. Sodium level, potassium level, calcium, phosphorus for our renal. So these are the KDIGO guidelines, which KDIGO staging, which has been used, like what category of eGFR patient is there and what category of albuminuria is there. Then accordingly, if green panel patient is falling into, this is the low risk of our patient to develop CKD. Yellow panel, moderate risk, and the red panel, their patients are at a higher risk of developing CKD. So definitely, and what ADA says, 30 milligram per gram, then 6 monthly it has to be repeated. If a normal USCR, annually it has to be repeated in our patient. Urine routine microscopy, we have to definitely look for high sugar patient. You have to look for ketones, pus cells, erythrocyte, leukocyte, cellular cast, which can help in early detection of our CKD patient. Talking about retinopathy, as we know, eyes are the mirror of diabetic complications. So our patient complications started, we can see, like if retinopathy is there, then we can say there are higher chances of developing other complication also. As we see, like if the patient is having CKD, almost always there will be retinopathy already developed in that patient. So fundus examination, retinopathy grading, most of us know grading has to be done. And diabetic retinopathy screening has to be done yearly, very important. And one of the very important thing which we miss, in all the pregnant ladies who are already diabetes, we have to screen for fundus before they are conceiving, because retinopathy deteriorates during pregnancy. So if there is no retinopathy or moderate, screen 3 to 12 monthly. Other stages like severe retinopathy and PDR every 1 to 3 months. Talking about neuropathy, pain is a gift without which we will not be able to protect ourselves. The root problem here in neuropathy is painlessness, which is very important. So pain is the protective mechanism of our body. Simple clinical tests, 3 tests which we can do: uniform vibration perception, 128 hertz uniform we can use, ankle jerk we have to see, Siemens-Winston 10 gram nylon monofilament, which is one of the very important aspect. At 10 foot points we have to see. If more than 4, then patient are having high chances of neuropathy. Now talking about diabetic autonomic neuropathy, so we usually miss this. It says, literature says that 5-year mortality with diabetic autonomic neuropathy is 3 times higher than in diabetic patient than without the autonomic involvement. So if we detect the autonomic dysfunction early, we can even prevent the MI and future CADs of our patient. So these are the diabetic autonomic neuropathy things which we have to see in our patient, but as I am only concise about the cardiac autonomic neuropathy, the simple tests which we have to, which can prove that autonomic has started, like resting tachycardia patient frequently having, orthostatic hypotension, that is like if the patient is lying down and if the patient is standing, after 3 minutes, if the systolic BP falls more than 20 mmHg and diastolic falls more than 10 mm, then there are higher chances of developing autonomic neuropathy and cardiac related risk. Exercise intolerance. In macrovascular complications, CADs, pulse rate, BP, fasting lipid profile, ECG, BMI, this will all guide us to any coronary artery diseases. Cerebrovascular diseases, if we talk about, we have to go for pulse rate, BP, fasting lipid profile, ECG, carotid bruise. Peripheral artery disease, simple two tests, just palpate posterior tibial artery, palpation of dorsalis pedis artery, which can prevent our diabetic foot complications in our patient. Local examination of the foot, I tell to all my patients, every night before going to sleep, just look at your foot. Because of this, because they don't have sensation, so they don't know, they don't have pain sensation. So you have to look for thin, shiny skin, foot is warm or cold, absence of hair on lower leg and foot, thickened nail, redness, crackles, callus and corns. ABI is also one of the important tests which can lead us to early diagnosis of peripheral arterial diseases. If greater than 1, 1.3, it is normal. If 7 to 0.8, mild. 0.5 to 0.6, it is moderate PAD. Less than 0.5, it is severe peripheral artery disease. So screen all our patient at first visit and then annually. If high risk foot is there, quarterly we have to screen the patient. What are the other investigation? USG abdomen, you have to look for, like you can see corticomedullary differentiation. You have to look, advise to the patient for USG, go for USG. And NFLD, you can see the excessive brightness in the fatty liver. And other investigation, SGOT, PT, which can help us in diagnosing muscle MASH and thyroid profile, as there are many relation with thyroid and diabetes. Now, these are the few questions I would like to ask. Which complication are this, if anyone can guess? Which is the commonest symptomatic complication of diabetes affecting 15 to 40% of all diabetes patients? Any guesses? Symptomatic complication? Neuropathy, right. Second, diabetic patient with albuminuria are more likely to die with cardiovascular diseases, definitely. Third, this is often asymptomatic in its most treatable stages. Retinopathy, good Anushri. Round of applause for Anushri. Good. So the key takeaways, I'm done with my presentation. It is not important to screen newly. It is actually very important to screen our patient at first visit. Let us move from glucocentric to the organocentric approach. So that we can delay the organ damage, we can reduce the economic burden of our patient by reducing the complications. And these are all easily available tests. We all can see, we all can advise this test. So you have to follow, treat the patient, screen the patient, treat the patient, screen the patient. Thank you so much. Let us just not make the noise and make a difference in society by screening all our type 2 diabetic patients. Thank you very much.
Very well explained in शॉर्ट टाइम एट द राइट टाइम. सबको ऐसे ही टॉक लेना है ताकि खाना और गाना बजाना भी एंजॉय कर सकें. सो इन्होंने बहुत अच्छा मैसेज दिया है कि समय पे आपको डायग्नोस करना है थ्रू बेसिक इन्वेस्टिगेशंस. सो बिग राउंड ऑफ अप्लॉज फॉर प्रियंका मैडम. या
थैंक यू.
अनुश्री,
I have one suggestion and one question for all the diabetologists. We also should screen for tuberculosis because weight loss and fatigue is quite common, and then we consider that it's because of diabetes. So we used to do a X-ray screening for a lot of patients who
actually, if we talk about the guidelines about ADS and all, they don't say chest X-ray is not there in them.
But
like,
in the Indian context, I think it's important to screen them for TB.
You know, the patient will already have the symptom of like cough with expectoration, with evening rise of temperature, night sweats, all this, and then we can go for that will be a better. If we screen all the patient, I don't think that will be justified.
Weight loss and fatigue?
That is there in type 2 early diabetic patient, that will be there. Yes, sir, you want to say something? Yeah.
Actually, regarding tuberculosis, what she has raised, in Indian patients, it's not routinely recommended that you screen every diabetic for tuberculosis, like HIV. Every HIV is screened for tuberculosis and receives INH prophylaxis. You must be knowing in ART center. Tuberculosis, you keep an eye. Any fever more than 2 weeks, you must screen for tuberculosis. Tuberculosis is more common, especially pulmonary tuberculosis. And extrapulmonary tuberculosis is also common. So any infection lasting more than 2 weeks should be screened. Keep an eye for the infections, diabetes and infection, keep an eye. But routine screening is not essentially patient is well controlled and immunocompetent. That's the guideline.
Yeah. Thank you, sir.
Madam Priyanka,
yes, sir.
there are 75% patients of the diabetic that die of cardiovascular disease. So what about TMT?
TMT, sir. So, like, sir, usually we don't advise TMT in all our patients. Initially, it is not set in the guidelines also that we have to screen the patient. Like, it depends on, like, if there are autonomic dysfunctions, definitely there are very large number of patients who are having coronary artery disease. Then we can definitely advise to those patients. But initial screening, it is not advised, sir.
It should be included.
Late to our clinics.
Yeah.
First they take exercise, diet, then Ayurvedic medicine. So by the time they come to us, they developed most of the complications. So we should screen, but the cost thing is the major factor.
Yes, sir. Because these were all simple to use tests and we can do in our clinics and easily.
Yeah.
That's
So thank you. मैडम के लिए बहुत तालियां हो जाएं.
Thank you so much.
Chairpersons, any questions?
Ma'am, those who are already on ATT, because diabetes and TB are basically hand-to-hand going. So the first line drug, the peripheral neuropathy is reversible, isoniazid induced. We have a prophylaxis. Suppose if somebody has already developed neuropathy, then what will be like your opinion in that regard, whether it is going to be basically beneficial or not, or we just should just continue with the treatment of peripheral neuropathy due to diabetes rather than drug induced?
So what you want to say, the peripheral neuropathy is already developed because of ATT?
No, ma'am. It is already developed because of
Tuberculosis.
because
Diabetes.
of diabetes. Yes.
Diabetes. So definitely ATT has to be given because these are the first line. Isoniazid mainly we are bothered about. So we give pyridoxine and all for reduction of that. I don't know exactly if we can omit isoniazid from ATT regimen. That will be
No,
like
we can't.
We cannot do that.
No, you must not.
Yes,
yes.
You must not omit isoniazid from the treatment regime. You continue with that and supplement the nutritional part to prevent treatment for ATT.
Further. We can give, yes, we can give like alpha glucose and all.
Okay.
Anything else?
Thank you,
Yeah,
Anand.
thank you.
Okay,
Yes.
thank you, Dr. Priyanka.
Thank you, sir.
For a very excellent and informative talk and covering the topic so beautifully.
Thank you, sir. Thank you.
Now we'll move to the next talk.
Thank you, Dr. Priyanka Kukreli, for such a lovely interaction. And I would now like to request our chairperson to facilitate our speaker. I also request our speaker to give memento to our chairperson. A huge round of applause, please. Can you? Saro. For our next session, I request Dr. Anushri Jamdar as a speaker and who would speak on the topic MASLD and beyond role of saroglitazar dual PPAR agonist. I also request our chairperson, Dr. Deepak Shukla sir, Dr. Akhilesh Tiwari sir, and Dr. Diksha Soni ma'am to present and introduce our speaker.
Hello. Dr. Anushri, she has done her MBBS in 2009 and done fellowship under Dr. V. Mohan sir and MRCP from 2018. She has experience in treating diabetic patients for about 5 to 7 years. You can start your session now.
Okay, thank you so much. So, ये लेक्चर मैं काफ़ी इंटरैक्टिव रखूँगी, बहुत इजी रखूँगी और बहुत क्रिस्प रखूँगी because I see there are people of lot of other faculties, not just diabetologists and endocrinologists, so I'll keep it very simple. So, हमको सबको पता है that the metabolic diseases in India are increasing and day by day the population with diabetes is increasing. 43% of undiagnosed diabetes lead to silent progression, and then obesity is another factor on which we were talking about, and that is again going hand in hand. So, पहले हम we used to use a term called as NAFLD, which is non-alcoholic fatty liver disease. लेकिन non-alcoholic alcohol की वजह से नहीं है, तो क्या वजह है? So we call it now MASLD, which is metabolic disease associated steatotic liver disease. So इसका name has been changed from NAFLD or NASH to MASLD. So that is what we call. So this particularly shows that obesity, prediabetes, hypertension, high triglycerides, they all lead to particular spectrum of diseases like MASLD, MAFLD, and the steatosis leads to all these problems. Now MASLD is more commonly seen in diabetic and obese patients for obvious reason, because abdominal obesity अगर किसी को है तो उसका पूरा का पूरा fat will go to the liver, and of course diabetes in itself leads to hypertriglyceridemia and dyslipidemia, which ultimately leads to MASLD. So in India the prevalence of MASLD is around 58%. So government अभी in fact is putting a lot of pressure and बहुत ज़्यादा screening चल रही है government maybe about MASLD. 1/3 of MASLD patients are suffering from liver fibrosis. 35% of Indian children are suffering from fatty liver, and fatty liver is commonly associated with both these conditions. Now this MAP study, it showed the prevalence of fatty liver and fibrosis at Indian diabeto-endocrine centers. So you can see that MASLD is very common. MASLD के से नीचे थोड़ा आता है liver fibrosis, and then ultimately these patients land up into cirrhosis. So zone-wise prevalence, like sir said, that these are patients are thin. So obviously the spectrum of disease is different in different parts of our country. But we can see that northern zone of our country, the prevalence of steatosis and fibrosis is maximum, and then subsequently it's in the other states like the south zone and fatty liver. It also raises the incidences of cardiovascular disease and CKD. Why this happens? Because obviously obesity, diabetes, fatty liver, they all go hand in hand. So if they are going hand in hand, obviously the incidence of CVD and CKD also progresses. Now insulin resistance is the main cause. जैसा हम सभी लोग जानते हैं, I'm keeping very simple. So insulin resistance होता है diabetic patients. तो इसीलिए तो diabetes में medicines and everything is mainly to address this insulin sensitivity को बढ़ाने के लिए. Now what happens? Insulin resistance is
तो insulin resistance की वजह से the medicines are not acting, so we need some medicine which will address this insulin resistance, and at the same time which can address this fat accumulation into the liver and the triglycerides which are common causes of the fatty liver. So type 2 diabetes is an independent predictor of liver fibrosis. So liver stiffness progression in biopsy proven MASLD and with and without diabetes. So we have seen that in spite of patients जिनको diabetes नहीं है and then diabetes है, both these kinds of patients have some kind of MASLD. But diabetes अगर किसी person, if somebody has got diabetes, the progression of MASLD to MASH, cirrhosis and hepatocellular carcinoma is much more in those patients who have diabetes than those who don't. So fatty liver with metabolic disease is associated with more cardiovascular events for the simplest reason because it goes again hand in hand, which is again self-explanatory. So low urgency for fatty liver screening in metabolic patients. So like Priyanka ma'am also said that it is very important that we screen these patients for any kind of fatty liver. They should be screened at initial visit and then subsequent visits they should be screened. Now who should be the ideal patients in whom we should screen? So anyone with liver steatosis on imaging, unexplained elevation of liver enzymes, first degree relatives of patients who have MASLD or cirrhosis. So these all kinds of patients, they should ideally be screened for MASLD. Apart from that, patients who are obese, have hypertension, dyslipidemia, PCOD, CKD, all these kind of patients should also be screened for MASLD. Now what this algorithm says, that if a patient has type 2 diabetes or obesity or any one of the following cardiometabolic risk factors or persistently elevated liver enzyme, then that patient should go for a fibroscan. If the fibroscan is the ratio is less than 1.3, then you have to reassess the patient. But if the ratio is high, then you have to give some intensified management for the comorbidities of that particular patient. And if it's quite high, then you have to have a hepatology referral for that patient and get him in touch with a hepatologist. So this FIB4 index is proportional to cardiovascular event and all-cause mortality. So this particular graph, it shows that the 10-year cumulative incidence and the risk of patient, the cardiovascular risk of event increases and the all-cause mortality also increases, whose FIB scans are higher. So the patients have a higher cardiovascular events and all-cause mortality. So this is a particular tool by which the patients are screened for MASLD. So what is the management? Iska treatment kya hai? So treatment is basically weight loss. Then we had a beautiful presentation on Mounjaro, GLP-1 analogs. So weight loss, jaise ki sir ne bhi bola that it's not very sustained and it is difficult to sustain it for a longer duration. So it is important that patients are treated for obesity like they're treated for any kind of diabetes or hypertension. So weight loss is highly recommended, but sustained weight loss is a big challenge. So there is a drug which is called as saroglitazar. So what this particular drug does is that it acts on the PPR alpha and gamma receptors in our cells. So what this particular PPR alpha receptor does? PPR alpha receptor increases the fatty acid oxidation in hepatocytes, reduces the fatty acid delivery to the liver, and hence it reduces the triglycerides and LDL cholesterol. But what it does on the alpha receptors? On alpha receptors, it increases the insulin sensitivity. So इस drug का dual benefit है. Alpha receptor पे काम करने से it reduces the triglycerides and LDL levels, but working on the gamma receptors, it increases the insulin sensitivity. And hence this particular drug is quite important and useful in patients who have MASLD as well as diabetes. That it also has an anti-inflammatory effect and hence it reduces the NAS more than 2 points in 52%, no fibrosis or worsening. Okay, so I'll just, so this shows that patients had a significant reduction in liver fat and ALT levels. So saroglitazar versus placebo, it shows that there was a reduction in ALT, there was a change in the liver fat content, and the patients, the percentage of patients with liver fat reduction by 10% and liver fat reduction by 30%. So that is what they have shown in this particular study. and it significantly reduces steatohepatitis over a period of 52 weeks from the baseline. It significantly reduces liver fibrosis, and so I'll come to the treatment part, that how it is started. So I'll just quickly. So this drug is particularly started at a dose of 4 milligrams per day, and sorry. So 4 milligrams once a day after breakfast it is started. The monitorings have to be done for LFT lipid profile at least once in 3 months. And the expected benefit is that there should be a reduction in ALT, triglyceride, liver fat, and improved insulin resistance. And of course there should be a reduction in triglycerides and improvement in the HDL level. So to summarize, the fatty liver with metabolic disease is global epidemic and commonly observed in type 2 diabetes and obese patients. Insulin resistance is a common cause for fatty liver with metabolic disease. The current major challenge is raising awareness and screening of patients who have MASLD for MASLD patients. FIB4 index is most recommended screening tool. Currently in India, saroglitazar is only approved medication for MASLD, and beyond MASLD, saroglitazar has potential as insulin sensitizer, triglyceride reducing agent, and it has better effect on liver enzymes, reduction in fatty liver patients, and it has neutral effect on serum creatinine, eGFR, and it shows a better alternative in patients with compromised renal function. Thank you.
Thank you, Anusri ma'am. It was very good talk, and we get the insightful things from this topic. Any question from the audience?
नहीं, सब चाह रहे हैं खाना खाना है, जल्दी जल्दी भगाओ.
I have one question. In our clinical practice, we often see patients who regain weight after initial success. In your view, what are the key strategies to ensure long-term weight maintenance and prevent relapse, especially in Indian lifestyle context?
Monjaro, like one they said.
Actually, Monjaro is a drug, but initially we take the Monjaro, we will reduce the weight. But what should we do to maintain this?
So lifestyle and diet modification are the only two things by which you can do. But like others said, that it is very difficult to sustain it for a longer time. So it is important and essential to consider obesity as a disease in itself.
Yes, metabolic disease.
Yes, and start treatment for that.
Thank you, sir.
Madam, I have one question. How many days we have to give, means in your experience, 3 months or 6 months? Then we are stopping, means what is the sequences of?
Sir, I don't have a clinical experience in saroglitazar. I think sir or maybe Bharadwaj sir can.
And it will reverse only enzymes or fibrosis also according to in FibroScan stages.
Sir, can you take this question because I don't have a.
So your question is the reversal of fibrosis and fatty liver. So this saroglitazar is working on the two parts. It is having the anti-hyperglycemic effect and reducing the liver fat. So it will help to reduce the grade of fatty liver, and even it can prevent the progression of fibrosis, but it cannot reverse the fibrosis.
How many days?
6 months at least.
Patient is discontinued.
No, then he will not have the positive benefits again. Or otherwise, if he is maintaining the weight, doing proper diet and exercise, then he may have the halt of that disease at that stage. But it is not that if you stop the drug, then it will be beneficial for lifelong. Thank you.
Sir, I have one question.
Thank you.
Sir, I have one question. Patients already diabetic dyslipidemic है और statins चल रहे हैं, fibrates चल रहे हैं, STBB भी चल रही है. अब ये बताइए कि इस पे add-on saroglitazar कितना benefit करेगा, या तो फिर साथ में co-prescription के साथ उसको दिया जाए कि मतलब कर दिया. सेम saroglitazar भी almost LDL को ही कम करने के लिए करती है और fatty liver और
When
fibrosis को
pioglitazone
reverse
is used, you cannot use this.
You cannot. So that's what I'm saying.
The
We cannot
mechanism
use
is factual.
Both the
It
drugs.
would
Yeah, Ajay.
act on the PPR.
There is PPAR alpha and
Alpha
PPAR
and
gamma
beta,
agonism. So pioglitazone is more of alpha and more of gamma, and this is more of alpha. So it is not an alternative to statin, but it does reduce triglycerides.
Yes.
Right?
Right. Thank you. Chairpersons, please come on the stage for felicitation.
Thank you, Dr. Anushri Ramdar, ma'am, for such a lovely presentation and interaction. I request our chairperson to facilitate our speaker on stage. I also request our speaker to give memento to our chairperson. With a huge round of applause, please. Moving on to our next session by our speaker, Dr. Ashish Dengra, who will be speaking on the topic, the soul of progress, transforming cardio, kidney, metabolic health with oral semaglutide. I also would request our chairperson, Dr. Umesh Pratap Singh, sir, Dr. Shyam Gupta, sir, Dr. Akash Jain, sir, to take a seat and introduce our speaker.
Akash, you can start immediately. जल्दी जल्दी खत्म करते हैं.
Hello.
I request our chairperson to introduce our speaker.
Good evening, everyone. Dr. Ashish Dengra is a renowned diabetologist in the city, and he rarely require any introduction. He is well known in the field of diabetes and thyroid and obesity. So I just request Dr. Dengra sir to please start the.
So without wasting time, I will start the topic on oral semaglutide as we were discussing with comparison with Monjaro. So the soul of progress, transforming CKMs, कार्डियो, किडनी, मेटाबॉलिक हेल्थ. हम इलाज क्यों करते हैं? एक तो शुगर कंट्रोल के लिए, दूसरा हमारे मरीज को जो कॉम्प्लिकेशन होते हैं उसको बचाने के लिए. तो मुख्य उद्देश्य इलाज का यही होता है. पेशेंट बोलता है हमें तो कुछ हो ही नहीं रहा है, आप दवाई क्यों लिख रहे हो? उसको यही बताना है कि CKM क्या बचाना है उसको? CKM, कार्डियो, किडनी, मेटाबॉलिक हेल्थ. So the semaglutide, why it is having importance in this present era of management, because it is well known that type 2 diabetes is not only hyperglycemia. शुगर के मरीज को डायबिटीज़ के साथ साथ और भी बीमारियां घेर लेती हैं. उसको हार्ट की बीमारी, किडनी की बीमारी, पैर की नसों की बीमारी और न्यूरोपैथी, नसों की बीमारी भी हो सकती है और स्ट्रोक, आघात भी हो सकता है. So इसको चालू करो. The burden of disease is interlinked is huge. डायबिटीज़ के साथ साथ वो बहुत सारे थैले लेके चलता है अपने साथ. थैले लेके चलता है किसके? वजन के थैला, हार्ट की बीमारी का थैला, किडनी की और लीवर की. जो बात हुई अभी की MASLD, नया चीज़ आया है कि फैटी लीवर. अगर मैं यहाँ सोनोग्राफी करवाऊँगा, जितने लोग यहाँ बैठे हैं, तो 50 से 60% लोगों को फैटी लीवर आएगा. तो ये हमारे खान पान, हमारे जो जीवन शैली बदल रही है उसकी वजह से. तो लीवर के डॉक्टरों की प्रैक्टिस बहुत क्यों बढ़ रही है, ये आपको सोचने की ज़रूरत है और समझने की ज़रूरत है कि आपको भी व्यायाम रोज करना है और खाना पीने में संयम बरतना है. आज तो खा लेंगे, कल एक्सरसाइज कर लेंगे, कोई दिक्कत नहीं. So we have to be vigilant. The type 2 diabetes rarely occurs in isolation. वही बात चल रही है कि सब एक साथ बोझा लेके चलते हैं. सो ट्रांसफॉर्मिंग द CKM, हमको क्या ध्यान देना है कि ये CKM को ठीक कैसे करें. सो द अर्ली इनिशिएशन, GLP-1 एनालॉग, ये भी वही दवाई है जो मॉन्जेरो है, उसमें 2 दवाई है, GLP-1 GIP, इसमें सिर्फ GLP-1 है एनालॉग. तो ये इसके ओरल संस्करण उपलब्ध हैं, उसमें इंजेक्शन लगाना पड़ता है, ये ओरल लेना पड़ता है. सो ओरली इट इज़ वेरी हेल्पफुल एंड ऑल द गाइडलाइंस रिकमेंड दिस, whether it is ESD, ESC, KIDCO, ADA, all these have shown that it is very effective drug. So rationale for early use is because it is having multiple positive benefits apart from sugar control. ये हमारे ब्रेन में काम करता है, हमको भूख कम करवाता है. हेपेटिक स्टीटोसिस, लीवर में जो फैट की बात चल रही थी उसको सुधारता है, किडनी को सुधारता है, ब्लड प्रेशर को नियंत्रण में रखता है, और इन्फ्लेमेशन, आजकल क्या बात हो रही, डिटॉक्स करने चलो, कहाँ चलो, ऋषिकेश, 70,000 रुपए दो, लेटो, मालिश कराओ, खाना ही मत खाओ, सिर्फ अपने को सलाद, लौकी का जूस और पूरा दिन ये देके और एनीमा लगा लगा के पूरा डिटॉक्स करके भेजते हैं और 70,000 रुपए ले लेते हैं. तो दैट इज इन्फ्लेमेशन. तो ये आपकी बॉडी का इन्फ्लेमेशन आपको खुद ठीक करना है. कैसे? आपका वजन सही रहेगा, आपका खान पान सही रहेगा तो इन्फ्लेमेशन कम होगा. हार्ट की बीमारी भी इसमें बहुत हद तक प्रिवेंट होती है. तो होलिस्टिक अप्रोच है इसमें. कहाँ कहाँ काम करती है? हर जगह, ब्रेन में, ब्लड वेसल, लीवर, पेनक्रियास, किडनी, हार्ट, हर जगह ये पॉजिटिव बेनिफिट देती है. रिबेल्सस, इट वाज द वर्ल्ड्स फर्स्ट एंड ओनली ओरल. डॉक्टर से जैसे भागता है ना मरीज की, जहां आपने इंजेक्शन लिख दिया, वो वाला इंजेक्शन तो अच्छे से लगाते हैं कि सर ताकत का इंजेक्शन ठोको, आज ठोका नहीं अगले हफ्ते फिर ठोको, उनको उसमें मजा आता है. लेकिन जब वो इंजेक्शन यहाँ लगता है तो वो बोलते हैं अरे आपने तो जहर लिख दिया. तो इंसुलिन का जो इंजेक्शन है उससे बहुत डरते हैं पेशेंट. तो ये जो नई दवाई इजाद हुई रिबेल्सस, दैट इज द ओरल सीमाग्लूटाइड, बट इट इज नॉट इंसुलिन. ये आप ध्यान में रखिए कि ये डिफरेंट क्लास ऑफ ड्रग है. सो एविडेंस विद रिबेल्सस ऑन CKM मेटाबॉलिज्म की कैसे वो प्रूव हुआ कि ये कारगर दवाई है कार्डियो रीनल मेटाबॉलिक पॉजिटिव बेनिफिट्स के लिए. पायोनियर ट्रायल किया गया. ट्रायल हम ज़्यादा नहीं पढ़ाएंगे. 1.5% reduction of HbA1c and weight loss by 5 kg. पर we have seen near about 8 to 10 kg and in some patients 15 kg weight loss with this drug, that is semaglutide. इसमें भी वही है, धीरे धीरे चालू करना पड़ता है. 3 मिलीग्राम, फिर 7, फिर 14, क्योंकि इसमें भी GI साइड इफेक्ट्स हो सकते हैं. Then there is high proportion of patients achieved composite HbA1c of less than more than 1% and body weight loss of more than 5%. हमारा उद्देश्य क्या होता है डायबिटीज के इलाज का? HbA1c, HbA1c, HbA1c. सब पेशेंट बोलते हैं HbA1c हमारा ठीक आना चाहिए, पर हमको CKM भूलना नहीं है. किडनी, जैसे बहरानी सर बोले थे, इको क्यों नहीं करते हो? तो CKM में कार्डियो भी आता है, उसको भी ध्यान में देके इलाज देना है. तो लिपिड प्रोफाइल पेशेंट खुद ही करा के आता है, ये हमारे लिए फायदे की बात है आजकल. CV रिस्क रिडक्शन, HSCRP कम करता है, लिपिड कम करता है, BP कम करता है. अर्ली इंटरवेंशन विल हैव मोर पॉजिटिव बेनिफिट्स, क्योंकि आपको कर्मा, जो कर्म आप करोगे तो आपको वैसा भोगना पड़ेगा. यही कहलाता है लीगेसी इफेक्ट. अगर आप शुरू में शुगर ज़्यादा रखोगे तो आपको ज़्यादा कॉम्प्लिकेशन होंगे. तो हमारे लिए दुर्भाग्य है कि आज इतनी सेमिनार, इतने एजुकेशन होने के बाद भी हमारे पास पेशेंट 5 साल 6 साल डायबिटीज़ ग्रसित होता है, उसके बाद आता है, क्योंकि वो पहले बोलेगा, पड़ोसी बोलेगा अरे तुम मर जाओगे, आयुर्वेदिक दवाई खाओ, एलोपैथी में तो किडनी खराब हो जाती है. तो पहले वो सिर्फ डाइट एक्सरसाइज से 6 महीने निकाल देगा, फिर किसी बाबा के पास जाएगा, फिर किसी को वो आयुर्वेदिक दवाई खाते है, वो उसको 4-5 साल निकल जाते हैं. तो तब तक हमारे पास जब मरीज आता है तो बहुत सारे कॉम्प्लिकेशंस होते हैं. तो अर्ली अगर आपने शुगर कंट्रोल करी, जिस दिन आपको डायग्नोज हुआ है उस दिन से आपने सही इलाज लिया, तो आपका कर्मा, मतलब कि शुगर अगर शुरू की नियंत्रित है तो आगे जाके पॉजिटिव बेनिफिट सालों साल मिलते चलते हैं, उसे कहते हैं लीगेसी इफेक्ट. सो अर्ली इनिशिएशन ऑफ रिबल्सस, रियल वर्ल्ड एविडेंस में देखा गया कि HbA1c रिडक्शन बहुत बेहतर है. सोल ट्रायल बहुत इंपॉर्टेंट है. सीमाग्लूटाइड क्यों सुपीरियर है? बिकॉज कार्डियोवैस्कुलर सुपीरियरिटी ट्रायल है ये, जिसमें 3 पॉइंट मेज देखा गया कि कितना पॉजिटिव बेनिफिट है. तो कोरोनरी हार्ट डिजीज, सेरेब्रोवास्कुलर डिजीज, क्रॉनिक हार्ट फेलियर, CKD और सारे जो साइड इफेक्ट्स हैं उनको रिड्यूस करता है ये दवाई. सो कॉन्कमिटेंट CV मेडिकेशंस भी चल रही थी सोल ट्रायल में कि किसी पेशेंट्स को BP था, किसी को कोलेस्ट्रॉल था। तो प्राइमरी आउटकम क्या था? 3 पॉइंट मेस वॉज रिड्यूस बाय 14%। हार्ट की बीमारी, नॉन फेटल MI रिड्यूस हुआ 26% से। सो द लार्ज रिडक्शन इन रिस्क ऑफ मेस वॉज ऑब्जर्व्ड अमंग पेशेंट्स विद HbA1c मोर देन 8 इन दोज विद एशियन रीजन। हमारा दुर्भाग्य ये है क्योंकि हम एशिया में रहते हैं तो हमको शुगर जल्दी होती है, हार्ट की बीमारी 10 साल जल्दी होती है, तो हमको और सतर्क चलना है। तो इसीलिए आपको जागना है, पेशेंट को जागरूक करना है। किडनी को खराब होने से बचाता है। डिक्लाइन इन एनुअल GFR is reduced, so heart failure outcome was positive, and oral semaglutide reduced the heart failure risk and CV death. This, you can see the hazard ratio was 0.78. The safety profile is very good. You have to start low, go slow. पहले लो डोज से चालू करिए, फिर धीरे धीरे उसका डोज बढ़ाइए 3 मिलीग्राम से चालू करके। So choosing the right anti-diabetic drug. एंटी-डायबिटिक ड्रग आप चूज करते हो तो क्या माइंड में आता है कि वो शुगर भी नियंत्रण में रखे, खाली पेट की भी, भरे पेट की भी, और कोई साइड इफेक्ट ना हो। तो रिबेल्सस में आपको ग्लूकोज लोवरिंग इफेक्ट मिल रहा है, बॉडी वेट रिडक्शन मिल रहा है, प्लियोट्रोपिक बेनिफिट्स, कोलेस्ट्रॉल कम करता है, वेट कम करता है, और आपका यूरिक एसिड, हार्ट का HSCRP जो प्रॉब्लम देता है, और साइड इफेक्ट जो हाइपोग्लाइसीमिया, जिससे हम डरते हैं कि पेशेंट आधी रात को बेहोश हो जाता है, तो उससे बचाता है। हाइपोग्लाइसीमिया के चांस बहुत कम है। थैंक यू। चेयरपर्सन, माइक दो, माइक। आ जाइए। एनी क्वेश्चंस?
Any question from the audience?
Madam, over to you.
Thank you so much, Dr. Ashish Dengra. So, now I request our chairperson to facilitate our speaker on the stage. I also request our speaker to give memento to our chairperson.
Hello.
A huge round of applause, please. Thank you so much. Moving on to our next session, I request our speaker, Dr. Ankit Agrawal, sir, to speak on topic exploring LDL-C management challenges in very high risk ASCVD patient. I would also request our chairperson, Dr. Ashish Tiwari, sir, and Dr. Manish Mishra, sir, Dr. P.N. Gupta, sir, and Dr. D.S. Behrani, sir, to take a seat, and please do introduce our speaker.
So, good evening everybody, and it's my pleasure to introduce Dr. Ankit Agrawal, an important pillar of Academy of Cardiac Sciences, Jabalpur, and he is one of the founder member from where the cardiology has grown from Jabalpur from at the stage where it is currently. So today he is going to speak on a very important topic, as the last talk has suggested that cardiac complication are among the most important. So among this, LDL and we will be discussing about in length about how this menace has come in diabetic and multiple cardiovascular complication has emerged. So, so we all aware that he's the director of Infinity Heart Center, Heart Institute, Jabalpur, and he did his MD from BHU, DM from IPG Mar Kolkata, and apart from this, he's a founder member of Academy of Cardiac Sciences, Jabalpur. So welcome, Dr. Ankit, please, and enlighten us on this important topic. Thank you.
Yeah. So good evening, everyone. Thank you, Chairperson. Thank you, Dr. Ashish Dengra. Thank you, NDID. And you know, I am on the speakers list, I think probably the last but one. I can see the fatigue in all the people who are sitting here. So I will make it crisp, try to tell you very few points which you all know, and then we'll proceed for the dinner. So the topic is LDL cholesterol management challenges in very high risk atherosclerotic and cardiovascular disease patients. So what is very high risk? So very high risk means that the patients who are having multiple vascular events even after optimal therapies. So supposedly if the patient had an MI and after 6 months he or she again had a cardiac event or a vascular event in the form of CVA, or although very not common, a peripheral vascular disease event. So even after getting a treatment, if the patient is destined to get repeated episodes of the same type of disease, then we have to be very cautious that whatever therapy we are giving to the patient is not optimal or maybe suboptimal. So if you see this slide shows that 80% patients who did not achieve LDL target goal in spite of getting statin therapy. And when we are talking of statin therapy, actually we are talking about guideline directed maximum tolerated dose of statins. So 80% patients did not achieve the LDL less than 55, and less than 70, around 50% patient was not able to achieve the goal. And this has been followed for 1 year. So we go to an arbitrary patient who is a young gentleman, around 39 years old. He's having an average BMI. He was on atorvastatin and ezetimibe, non-hypertensive, and his current LDL is very high, is 154. He's a software engineer, and he had a sedentary lifestyle. And you know, if you remember, you know, the ace cardiac surgeon Devi Shetty says that India is a land of paradox, in which our old father brings his young son to a casualty with a heart attack. So this is, you know, this is very, very, we see always the father is standing with his son in the casualty and says that my son is having a heart attack, I am fine. So this is what, you know, this type of typical thing is that a young person has landed with an STEMI. An STEMI is as good as an STEMI, and he had to be stented in this current hospital admission. So Abhay is struggling to adhere to his treatment due to his busy lifestyle and professional demands. There's another gentleman who is around 60s. He's also on rosuvastatin and evolocumab every 2 weeks, non-hypertensive, and his LDL is 80 milligram. He is hypertensive, diabetic. He has undergone 2 PCIs in last 3 years. So he's having multiple cardiac events. Now Ramesh finds it difficult to adhere to treatment due to high treatment burden of existing lipid-lowering therapy. There's another patient, Mrs. Kalpana, who is hypertensive, obese. She also underwent, she is 52, underwent PCI, multivessel disease, 2 stents, one in LED and other in the right, and she is concerned about the risk of having another event. So these 3 patients are 3 different patients. One is working as a software engineer, one is a little bit old, and one is a middle-aged ladies. So these are all extremely high-risk individuals. The slides are not very clearly visible. I don't know why. So the goal is the more high risk you are, the less should be the LDL. Somebody asked, can we have an LDL of 0? Can we have an LDL of 0? Nobody knows. There is no J-shaped curve like hypertension that if you go beyond, below some level, there will be increase in events, but lower the better. There are people who are after receiving this inclisiran, the LDL, I saw one lipid profile around 2 weeks back. The gentleman's LDL was 1 and he was absolutely asymptomatic. So he has received inclisiran for last 2 years. Previously he was in United States and now he has come to Jabalpur, relocated to Jabalpur. And what has happened that he had 2 events, one carotid angioplasty and one PTCA to his coronaries, and he was started on inclisiran and his LDL is 1 and is absolutely fine, no side effects. So lower the better holds good. They say less than 40, I say less than 30. You should not aim to eradicate the LDL from the body, but if you can get a lower LDL level, that is fine. So these are the guidelines which says strike early and strike strong. Like, you know, the blood pressure, when we start treating the blood pressure, it is not like this. You keep on increasing the dose of one drug till you get the maximum tolerated dose of that drug, and then you switch over to the other class of drug. Instead, you start in an armamentarium with 2 different class of drugs, so that you can get a blood pressure control with 2 drugs early as compared to 1 drug in a long term. That is how the statin therapy, dyslipidemic therapy is. Instead of waiting for 1 drug to escalate and then achieve the goal, you can go all guns blazing and reduce the cholesterol to maximum to the guideline levels. So this is how it is. Sorry. So in all these patients, you see the LDL was quite high, and in all these 3 patients, the goal was not achieved. So Abhay, Ramesh and Kapna are very high risk patients and require an effective and sustained lowering of LDL cholesterol. There is something called cholesterol years. Cholesterol years means it is not at one point of time that when you have a high lipids that you are exposed to the disease. It is how many years you are having dyslipidemia. That also contributes to the disease burden. So currently available, what you have, the drugs, we all know, statins, ezetimibe, bile acid sequestrants, PCSK9 inhibitors. Then these are alirocumab and evolocumab. New therapy is inclisiran, which is small interfering RNA, bempedoic acid, and there are some emerging therapies. Combination therapy is needed, which I said. So if you see this, moderate dose statin with ezetimibe, you can achieve a goal in 65%. But if you add PCSK9 inhibitor with high dose statin, the lowest one, you can achieve a goal in 85% of individuals. So it is very important that you start with this in high risk individuals. Intensive lipid lowering therapy, including intensive statin, ezetimibe and PCSK9 inhibitors, was associated with significant odds reduction in MACE events. So early benefit, so you see the curve starts diverging when you start the statins early. So what is the CV outcomes with early initiation of lipid lowering therapy? If you see the IT trials, ezetimibe and simvastatin versus simvastatin alone. In first days, if you see 10 days only, the curve used to divert. So impact of PCSK9 inhibitors on patients with prior PCI at 48 weeks. There is 61% decrease in the LDL. There is decrease in 18% of major coronary events. 23% requirement for additional PCI, 24% reduction in the PCI de novo, and there is 24% reduction for the previous stents and graft vessels failure. So this is how it is. Which of your patients can benefit from addition of inclisiran? The answer is this. And the best part is, you know, benefits versus existing therapies. It is only a 2-dose yearly injections. There is no side effect of this drug. Only a flu-like reaction can happen initially. Otherwise, I don't think there is any major side effect of this drug. So this is how it is. With inclisiran, 68% of patients achieve LDL level less than 70, and 52% achieved less than 50. So this is the Orion trial, which is a trial for inclisiran. So there is a 2 doses regimen, initial dose, and then second dose at 3 months, and then every 6 months. That's all. Now, the question is, if you should not go by the impression that if the patient is on inclisiran, the patient should not be on statin. No. The patient should be on statin. Your goal is to reduce the LDL. You can reduce the dose of statin, and in particularly the patients who are statin intolerant, you can get away with statin. But don't avoid the patient or don't divide the patient of getting statins. I think in the context of time, I open this talk for discussion if there is any questions. Thank you very much. Yes.
Sir, it is not a question, it is a comment. Basically, we should be discussing the Lipid Association of India guidelines because they are India specific. They have a added category of very high risk patient, category A, B and C, where the optimum LDL target is about 15. And you are very correct that PCSK9 should be employed, starting with statins, escalate the dose of statins. If they tolerate, add ezetimibe, add bempedoic acid because of the cost factor, and then we can add PCSK9 to achieve the goal. So I request you that you must discuss the LAI guidelines because it is India specific. Thank you.
The LAI also emphasize on the same thing which has been told in the slide. They have actually bifurcated the very high risk individual into 4 categories.
Yes.
And further they have said, see, the crux of all these guidelines is the higher the risk you have, the lower the LDL you should have.
Definitely, but the European or American guidelines, they stay at above 50.
Less than 70.
Less than not 50, but the LAI guidelines optimize the very high risk category C to 15 milligram % of LDL.
Yeah. So I told sir, can I have an LDL of 1 or 0? So I said
no, that is okay. That is
no harm.
Just mentioning the LAI guidelines
will
be better for our audience.
Our audience,
yes.
Just to comment and congratulate the LAI guideline, whatever they have suggested in 2017, like they suggested less than 25 for very high risk patient, less than 40 for 2017 when the international guideline were 50 or 70. The same thing is followed all over the world. Yes. So whatever they have suggested 5 years back, now the whole world is following that. Right. So probably we are
in Indian setup, mentioning LAI guidelines is important so that the message goes to the ground level physicians that Indians are also doing good.
And it does make sense when we Indians and South Asian getting heart attack in a younger age, right?
I think Dr. Ankit Agrawal has enlightened us upon the how much is the lower is your goal in your when you are doing the second PCI, third PCI, how 30 is the proper goal or 50 or 70?
So sir, you know what sir has rightly said, if you go by the LAI, so they have come with an idea of getting LDL less than 30 also, less than 30. So, you know, the concept is you are only lowering the LDL. The people say that, you know, if you don't have any cholesterol, how you will survive, because you have membranes, you have proteins, you have hormones. And, you know, the cholesterol is an integral part of all these things. The question is, you are only reducing the LDL. You have VLDL, you have non-HDL, the other chylomicrons, which can do the same work. So, you are actually only reducing the LDL. So, less than 30, I said, you know, I saw an LDL report around a week back, which was having an LDL of 1 after receiving an inclisiran. So, it is fine if you are able to achieve it. And if you are particularly high risk, having recurrent events, then lower the better. Maybe, I don't know, you know, the medicine is an ever evolving science. It may become that if you don't have LDL, you are fine. I don't know, the day will come.
In one of the meetings, Braunwald said that you should focus the LDL at the age of 20 and keep it below 30, you will not have any coronary artery disease.
So yeah, so you know, there is a very important anecdote. There is a city called Milano, that is near Milan, you know, where there is no LDL. So the people living in that area, they have no atherosclerosis. So hardly die of heart attack. So that is true.
Thank you, Dr. Ankit. You have enlightened about the lipid management of especially targeted LDL, targeting the LDL in an excellent way. Thank you, Dr. Ankit.
Thank you. Thank you so much. Yeah.
Thank you, Dr. Ankit Agrawal, sir, for such a lovely interaction. I now request our chairperson to facilitate.
It is felicitate. Don't worry, yeah.
Fuck, I'm panicking right now. Our speaker. I also request our speaker to give memento to our chairperson. Moving on to our next session, I would like to call the speaker Dr. Arvinda Jagdisha to speak on the topic Harnessing AI in Diabetes, Weighing the Pros and Cons. I also request a chairperson, Dr. Hemen Tilagam, Sir, Dr. O.P. Raichandani, Sir, and Dr. Abhiraj Bhattacharya, Sir. I request the chairperson to introduce the speaker, please. I request Dr. O.P. Raichandani as a chairperson, please.
हाँ पेन ड्राइव से डायरेक्ट लगे कौन सा वाला है सर इसमें
अभी निकाल रहे हैं
वन इन
we welcome Dr. Arvinda J for his presentation, and without wasting much time, I would like to request the speaker to start his session.
के लिए सर ने हमारे ओके किया है. So without wasting time, I will hand over the session to Arvinda for oration.
So good evening everybody. At the outset, I thank Ashish and NDID team for considering me for this oration. This is the first time I am giving oration at 10:30 p.m. So usually it was in the morning. So I am happy to see the people sitting at this time ready for the dinner. In between I am become an nuisance, but I'll try to finish it off fast as early as possible within 10 minutes. So first of all, greetings to all from Bangalore. So AI hype or the clinical reality. So what is AI? So it's when a computer mimics human intelligence to perform a given task that is example medical diagnosis. What is ML? A subset of AI that learns to perform given task from data and improves with experience. Deep learning is a subset of ML that uses a large neural networks and big data to better solve complex problems. So what are the types of artificial intelligence? So based on capabilities, narrow AI, general AI and super AI, based upon the functionality, self-awareness AI, theory of mind, limited memory and reactive machines. So way back from 1950, there are various parameters the AI has evolved. So AI tools in healthcare, if you take, it is helpful in clinical practice, biomedical research, public health and health administration. So current uses of AI in healthcare, so the medical diagnosis, personalized treatment plans, drug discovery, robot-assisted surgery, remote monitoring, and most important, electronic health records. If you take chronic health conditions considered to be benefit from AI, infectious disease, neurological disease, cancer, heart disease, and most important, diabetes. It accounts to 66%. This is the most important slide, and if a takeaway slide also, the pros and cons. So the pros are the better data-driven decisions, increased disease diagnosis efficiency, treatment type cut in half, integration of information, reduce unnecessary hospital visit, create time-saving administrative duties. Cons, concerns regarding privacy and security, lack of curated healthcare data, high initial capital investment, lack of interoperability, reluctance from staff to embrace AI, potential for increased unemployment. So AI and diabetes, the next frontier. The various case reports are there which has shown the benefits of AI. What are the challenges in traditional diabetes management? Mainly the shortage of specialists, poor medication adherence, and inefficient resource distribution. So that way back from 1920s, from the insulin discovery to the present era, there are various discoveries in AIs and ML which is going on for the development of management of diabetes. Why AI in diabetes? Because of the rising prevalence, great economic impact, need for scalable solution, complexity of diabetes, need for precision and personalization. Diabetes self-management can place a heavy mental burden on the patient. So AI for predicting and diagnosing complications of diabetes like screening and prevention, diagnosis and prognosis, treatment and management. I'm sure in many of our clinic setup, we have got a retinopathy camera in our things where we do retinopathy screening. That photos can be sent to the specialist and get an immediate opinion within 10 to 15 minutes. We can diagnose diabetes retinopathy. If it is advanced, we can refer to the specialization center as soon as possible to prevent the major complications. Then there is a decision support, diabetes clinical decision support. We have got insulin pumps, CGMs, where it will help us in the management of diabetes. Patient self-management tools, yes, there are some aspects like CGM with Sugar IQ app, which was approved in 2018. The model was trained as an anonymized CGM data from more than 10,000 users. The promise of autonomy beta bionic islet pump. So currently available semi-automated insulin delivery systems require individualized insulin regimen. So it was initialized using the patient's body weight, no carb counting, corrections or present basal rate. So what is the promise of autonomy? That is beta ionic islet pump. Most important is no carb counting, no correction, islet algorithms, and no preset basal rate. So the risk prediction and stratification is an important aspect of AI in the management of diabetes. If you take AI in diabetes diagnosis, there are novel markers. So one is the digital biomarker. So what is that is the deep neural network on smartphone based photoplethysmography data. The data was obtained by placement of a finger on a smartphone camera, and using the app you can predict the diagnosis of diabetes. The second one is vocal biomarker. Just by talking for 6 to 10 seconds of people's voice along with age, sex and height and weight, you can distinguish whether the individual has got type 2 diabetes. The model had an accuracy of 89% in women and 86% for men. So there is one important concept, that is AI for diabetes remission, that is called as the digital twin. It is a virtual replica of a patient's health status by using ML to develop predictive modeling and personalized approaches to DM. So this you can see, this is the digital twin where the personalizing insulin therapy to improve glycemic control while circumventing daily challenges of diabetes management. So it uses the geolocation, identifies restaurants and menu with estimated carbs, clue detects meal initiation, duration and quality of meal, accelerometry and heart rate monitors, identify amount and intensity of exercise. So large language models, I'm sure all of you are using, sitting here only, the chat GPTs, which you are, if you have any doubt, immediately you put it in a chat GPT, you will get the answer. There is no need of any talk or presentation, or immediately this presentation you will get in 10 minutes. That is the AI things is going on. But what are the challenges and ethical consideration? Mainly data privacy and security, bias and representativeness in data, the transparency and explainability, and accessibility and equity in healthcare. So we are using insulin injection technique, we are using the apps, you are using, telling the patient, transferring them the apps, within 10 minutes they can learn how to give the insulin by using the smartphone. Then we have various blood sugar monitoring thing which are available in the market, and most important is monitoring of diabetes complication. If this is very important, if the person is having a diabetic foot, if you assess this, you can tell whether the person is going to develop complication, foot complication, ulcers, or any other gangrene in the future. And Google Smart Lens, needle-free revolution, smart insulin pens, artificial pancreas, and automated closed-loop system. So whatever the future brings, it will be undoubtedly make a huge difference in the lives of millions of people worldwide. So the global health workforce shortage is imminent. So AI plays an important role in the management. So the implementation of artificial intelligence is a true challenge. We should accept the challenge. So the medical community should not fall for the fear mongering around the AI. We should not think AI is coming, my job will be gone, we will be having problems. The radiologists feel that AI is taking over everything. What job I will do? What the diabetes doctors will do? China is introducing doctor-free lab where the patient can walk in without doctor, he can get the prescription and come back by a full body assessment. So these things are going, but we should not have that fear mongering. So what we should remember, whatever said and done, whatever AI we accept, but AI cannot replace empathy, isn't it? So without human touch, nothing works. So the challenges of AI in healthcare sector, these are the most important. Mostly there are in the process of clearing all these things like ethical clearance, clinical implementation concern, social concern, data collection and algorithm developing concern. So we are witnessing the first innings of transformative era in healthcare. Though development of AI holds exciting promise for the field of medicine, there is still a need for caution when using AI. So most important, the pipeline of AI-driven products promises a future where care for diabetes is more effective, integrated, and patient-centric, revolutioning early detection, empowering self-management, enhancing decision support for clinicians, comprehensive patient education, and alleviating the burden. The future of AI in diabetes care is not just about technological advancement, it's about creating a more humane, personalized, and empowering healthcare journey for millions of people living with diabetes. So remember a movie way back, so where Rajinikanth played this role, robot in Enthiran, using AI tools meant to help, but it lacked emotion. So, but we rely too much on it and ignore the human aspect. It could be like Chitty putting healthcare at risk. So, we should be very, very careful. So, combine it with a strong doctor-patient relationship and invest in digitalization of records, elderly-friendly texts, and patient education. use AI for what it does the best, like data crunching and pattern recognition. So this should not be the case. See this, it is saying in 2040, dying in the operating table because my doctor used Chat GPT to pass the medical school. Funny now, but let's make sure AI supports medical learning, not replaces it. So everything may say, the AI people may say, they have got Gemini, ChatGPT, Midjourney, Copilot, AlphaCode, Synthesia, Compose, all these things are available. But most important, we should always say, mere paas personal touch hai, empathy, sympathy and experience hai. That is what is most important. So thank you for your patience hearing.
Congratulations, Dr. Arvinda, for this oration. Technically, we cannot ask questions, or we can ask Dr. Dengra.
डिनर के समय क्वेश्चन पूछ लेंगे एआई पे रोबोट से. सो दिस वाज डॉक्टर वीके मेहता सर ओरेशन. प्लीज स्लाइड चलाइए वीके मेहता सर की. थैंक यू. वेल ऑन टाइम. So Dr. V.K. Mehta sir was a very well renowned physician and academician, and he was HOD of medicine department for many years, and he was a very keen and for teaching the students, and their chest physician, he was practicing as a chest physician and physician. His diagnosis of chest diseases were excellent, and we have learned many things how to diagnose the chest diseases through percussion, stethoscope. So nowadays, jao X-ray kara lo. No, on that time, X-rays were not. Now AI use karo. So, like females come to our clinic and they say, डॉक्टर आप हो कि हम हैं? उनसे पूछो कि क्या तकलीफ है, तो बोले आप बताइए. तो हम पेशेंट है, आप डॉक्टर हो, तो आप पहले से जान जाइए कि हमको क्या क्या तकलीफ है. So like that they want the AI thing from that era. Now it is coming up. So we should give a big round of applause to Dr. V.K. Mehta sir. Now citation.
आपका पेन नहीं निकाल दूँ.
So NDID is privileged to award Dr. Arvinda Jagdisha Professor from Bangalore the late NDID Dr. V.K. Mehta Oration 2025. A big round of applause for Arvinda. And he is MBBS MD from JSS Medical College, Fellowship in Diabetes and Endocrinology from the Witbushi General Hospital, Wales, UK, MRCP, Royal College of London, FRCP, and from Edinburgh, UK, FRCP from London, and FRCP from Glasgow. इनके पास 3 FRCP हैं, बहुत तालियां. So कुछ ही डॉक्टर है पूरे इंडिया में जिनको FRCP ट्रिपल है. One of the few doctors with MRCP with triple FRCP received Best Eminent Diabetologist of Bengaluru from IMA, Bengaluru branch, and he has received Economic Times Most Inspiring Diabetologist and Endocrinologist of India 2022. He has received Times of India Healthcare Achievers Award in the field of diabetes and endocrinology in 22nd December 2018 Bengaluru. He has received the Bengaluru Highest Civilian Award. बहुत तालियां हो जाएं. For the work in field of diabetes in August 18. He has received felicitation and diabetes Vaidya Ratna Award from the pupil of his hometown on occasion of Basava Jayanti and Mysuru district. Received Diabetes Awareness Initiative Award in Diabetes India, and now working in his own exclusive integrated diabetes care center, Dr. Arvinda Diabetes Center, Bengaluru, as chairman and chief diabetologist with all facilities under one roof for the diabetes care. He has vast experience of working in various hospitals in UK, especially in the field of diabetes and endocrinology. After finishing the fellowship in diabetes and endocrinology from the UK and MRCP, he has done and came back to India. Over 100 conferences, presentation, उससे ज़्यादा ही हो गए होंगे अब तो. 30 publications and involved in clinical trials conducted at his own center. He is eminent speaker at both national and international conferences, webinars. He was the president of RSSDI Karnataka chapter, and he is presently the elected executive committee member of National RSSDI, जो सबसे बड़ी body है diabetes की पूरे इंडिया की. उनके ये executive member अभी vice president हो गए अब. Now he is elected as vice president this year. तो तालियां, sir. आइए. ये ओरेशन है, तालियां बजती रहें. Thank you Arvinda for accepting the invitation. VK मेहता सर के बारे में थोड़ा सा बताना चाहूँगा. Will you do the honor?
Yeah. So Professor VK Mehta sir is born in 20th February 1947 in Hoshangabad. He was schooled in SNG High School, Hoshangabad. He got admission in 1965 batch NSCB Medical College, Jabalpur. He did MD Medicine from 1971 to 74 under Dr. Surendra Singh. Selected as Assistant Professor in GMC Raipur on 1965. He went to Indore to do DTCD on deputation in 1965. In 1977, he got posted at Jabalpur and was in Jabalpur till retirement. For 18 years, he was lecturer. He took the charge of head of the department in 1996 and remained HOD for 14 years. He had 50 publications in his name. I am extremely honored to receive Professor V.K. Mehta sir. Thank you, Dr. Ashish.
Thank you so much. Moving on to our next session, I would like to call our speaker, Dr. Ravi Dore sir, to speak on the topic Recent Advances, Management of Diabetic Foot Ulcers. I would also like to call our chairperson, Dr. Manoj Murali sir, and Dr. Raj K. Jain sir, to introduce our speaker.
Dr. Sheikh, can you be the chairperson for this session? Come. आपको जानकर खुशी होगी कि बांग्लादेश से डॉक्टर अटेंड करने आए हैं, ये मुझे अभी पता चला. डायरेक्ट वो सीधा लैंड किए हैं जबलपुर. He is Dr. Sheikh from Bangladesh and he will be the chairperson for today's session. Thank you. Okay. Yeah, so Dr. Dore is a very good friend of mine and he is consultant physician from MGM Hospital, Katni, and he has a special interest in diabetes and is certified postgraduate diploma in medicine and endocrinology from American Diabetes Association and speaker in various national and international conferences.
Good evening everyone. Today I am going to discuss about the recent advances in the management of diabetic foot ulcer. So in the coming slides we will summarize the recent diagnostic and the therapeutic advances for the diabetic foot ulcer and understand the new devices and the biological therapy and the use of the telemedicine or AI. So as we know, diabetic foot ulcers affect 6 to 10% of people with diabetes during the lifetime, and the major cause of non-traumatic limb amputation and the high healthcare cost. So whole discussion is focused on the international working group of diabetic foot 2023 guidelines. So it includes the multidisciplinary approach. It should include diabetologists, surgeon, podiatrics, vascular specialists, and wound care expert. And we should strategize the early identification of neuropathy, any evidence of ischemia and deformity to prevent the ulcers. So, and offloading and the infection measurement is the still basis and a core of the management of diabetic foot. And in part of this, revascularization and bone healing add-on therapy, including the negative pressure bone therapy, bioengineered skin, cellular therapies are important whenever there is a fail of standard care. So amputation should be prevented with all measure, and patient should be educated about the regular foot inspection, which is very important for the recurrence. So in a recent diagnosis, toe pressure measurement, percutaneous oxygen and ultrasound remain the mainstay. Apart of this, we can use the endocyanin green fluorescence for decision making whether there is a concern of the amputation, and we could also consider MRI angiography or CT angiography when there is a vascular occlusion. So revascularization advances, should be an endovascular first approach, and for a lower limb lumen sparing technique and drug coated lumen and the atherectomy, and we can also consider for both of these. So endovascular approach include intravascular lithotripsy, atherectomy, angioplasty, and to reduce the significant calcification, increase collateral circulation and reduce reocclusion. So this is the study comparing the both drug coated balloon and the atherectomy for the intrapopliteal region, but over the long term the outcome was almost similar for both the therapy. So this is a very common and device negative pressure bone therapy when it should be considered for improving granulation and the healing. And these are the new things and in the management of diabetic foot ulcer, and most of the things are under development. So we can consider a bioengineered substitute. It could be cellular, acellular, including alloderm, dermacell, or derma matrix, and other is cellular skin substitute like dermagraft, transcyte, ICX, SKN, and denovoderm. And the topical growth factor and the combination of biologics are selectively used whenever there is a difficult to treat diabetic foot ulcer. We can consider bicalpermin and epidermal growth factor like Haberprot and Riseth D and EGEF. And the cellular therapy and the regenerative medicine, mesenchymal stem therapy and the platelet-rich plasma, and their combination is enhancing bone healing in slowly improving diabetic foot ulcer, and the evidence are promising, but there is concern about the safety. And the apart of all the recent advances, antimicrobial management is still a cornerstone in the management of diabetic foot ulcer. So with the emergence of the technology, telemedicine is the part of the recent management, including the nurse-led telemedicine demonstration, comparable healing outcome, and remote monitoring, and photos and wearable sensor support, early intervention, and multidisciplinary approach. So practical recommendation: perform early vascular assessment for the ischemic diabetic foot ulcer, consider endovascular revascularization whenever possible, use non-removable offloading for the plantar neuropathic ulcer whenever possible, consider negative pressure bone therapy, bioengineered skin or cellular therapy for non-healing or difficult to treat ulcer, and integrate the telemedicine and the community medicine for the follow-up and prevention. Thank you.
Thank you. Any questions?
Thank you. Any questions? Dinner में साथ कर लेना.
Thank you, Ravi. We will have a felicitation process. Come. जितने लोग बैठे तालियां बजती रहनी चाहिए.
Thank you so much.
Thank you.
So,
Next chairpersons.
moving on to our next session, I request our speaker, Dr. Ashish Dengra, to speak on the topic, clearing the air around inhaled insulin for Rediscover 2025, a new innovation for diabetes management. I would also like to call a chairperson, Dr. Sanjay Nema, sir, and Dr. Satendra Mishra, sir. I request chairperson to introduce our speaker.
The newer insulin which is now available is Afrezza. उसको बुलाओ विकास को.
I request the chairperson to introduce our speaker.
Slide तो लगाओ. नहीं वो वाली चेयर पर वो हर बार सीवी स्लाइड लगाओ ना. तुम सो जाता है क्या हर बार? क्यों भाई इधर?
Dr. Ashish Dengra is well known to all of us. Actually, he needs no introduction. He is a leading diabetologist of entire Mahakoshal area. He has attended many national and international conferences. He was a speaker in many nationals and international conferences also. He has presented many papers in nationals and international conferences.
Thank
now
you.
he will speak on the inhaled insulin.
Thank you, respected chairpersons. The next slide, presentation please. So I will be dealing on the newer agent Afrezza, that is the inhaled insulin. पहले इंसुलिन जो बनता था वो एनिमल से बनता था, पर अब we will be seeing very soon the inhaled insulin. So clearing the air around the inhaled insulin, इसमें क्या क्या आपके queries हैं that we will discuss in few minutes. That it is supported by CIPLA. The today's discussion is how insulin was discovered, and inhaled insulin is now will be available very soon in Jabalpur also, and what's the evidence and conclusion. So gradually from animal to human insulin, and now rDNA technology insulins are available. First there were the basal intermediate insulin, now the long acting basal insulin are available, short acting, rapid, ultra rapid acting. So gradually the progression, जैसे आपका मोबाइल है S3 Ultra, फिर S4, S24 Ultra हुआ, Pro Max. So like this the insulin has been developed since many years for betterment of patients and how the advantages are there. So this is the inhaled insulin, a century old wonder. In all this progress, one aspect continues to be common, that is invasive route of administration for insulin. तो patient क्यों डरता है? हमारे क्लिनिक पे आया एक पेशेंट, उसको बोला कि आपको इंसुलिन लेना पड़ेगा, 600 शुगर थी, HbA1c 15 था. वो बोलता है अगर आपने मुझे इंसुलिन लिखा तो मैं सुसाइड कर लूँगा क्लिनिक के सामने आपकी. तो मैंने कहा भैया तुम गोली लो और घर जाओ, सुसाइड यहाँ मत करो. So the innovation of inhaled insulin is now available, and it was initiated in 1925 in Germany. Then Wigley and colleagues administered this aerolized insulin via nebulizer to rabbits, but they were not successful. Then in 2006, Pfizer launched Exubera. The US FDA approval was given, but they withdrawn from market due to some carcinogenic effect. Then US FDA has approved now Afrezza inhaled insulin developed by Mankind Corporation because of the Technosphere technology in 2014, and now it is collaborated with CIPLA for Indian market. Afrezza is a Technosphere insulin, the only inhaled insulin available for use, and it is the US FDA approved insulin and commercially marketed in US since 2015 February. Now formulated using Technosphere. Why it is important? Because insulin adsorbed onto carrier particles that are fumarate, decatopeprazine and polysorbate 80. Now this drug goes into the respiratory system and then it is absorbed in the circulation. So drug and device combination are compact inhaler. It is very small, you can see here, and this is the inhaler, and the cartridges are 4 unit, 8 units and 12 units cartridges are there, which are pre-filled single-use cartridges. So breath, powered delivery, oral inhalation. जैसे हम अस्थमा के लिए कैप्सूल खींचते हैं, ऐसे ही ये वाले cartridges अब available रहेंगे. तो ये नई innovation डायबिटीज के क्षेत्र में आ रही है. क्यों नहीं मूव कर रहा? देखो स्लाइड ही नहीं मूव कर रही, हैंग हो गई है. So this Afrezza or inhaled insulin will be available in the near future within few months or weeks, because now what is the evidence? The pharmacological profile is very, it is rapid acting insulin and demonstrates quicker onset versus the other available insulins closely resemble endogenous insulin, because the endogenous insulin time to measurable effect is 10 minutes. The similar with the Afrezza, it is 12 minutes, but with the available subcutaneous insulin, it is 17 to 30 minutes. The time to peak effect is 45 minutes, similar to the endogenous, and time for effect to return to basal is 210 minutes for the endogenous insulin, and Afrezza is 180 minutes. So it is mimicking the physiological insulin. The type 1 clinical efficacy in type 1 diabetes patients, it is significant, the Technosphere in type 2 diabetes patients, they have shown significant reduction in HbA1c, and postprandial excursions have also shown. All-cause hypoglycemia was very less, 0.5, and severe hypoglycemia was 0.6. Now, the similar HbA1c reduction and lesser hypoglycemia compared to other rapid-acting analogs, as you can see in the bar diagram. So, phase 3 clinical trials, whether they have cough, throat pain, headache, diarrhea, productive cough, fatigue, nausea, all these was studied, and they were having little side effects of cough, reported in 26.9% of Afrezza patients compared to 5.2 comparator treated patients, and 94% of cough episodes were characterized as intermittent or single episodes. So it is really transient, and it declined with continued use of the Afrezza. So cough was the most common reason for discontinuation in the clinical trials. 2.8% patient treated with Afrezza discontinued therapy because of cough in the clinical trials. All group had small decline from baseline, a mean FEV1, and the pulmonary safety, the difference was resolved by up to follow-up visit of 4 weeks after discontinuation. The lung safety with Afrezza has been evaluated in 2-year study because the previous drug was withdrawn because of the lung carcinogenic effect. So changes in FEV1 was small, occurred early, remained non-progressive up to 2 years, and resolved when treatment was discontinued. So very little decrease in the FEV1 was seen, and the change in FEV1 in phase 3 clinical trials, 1 out of 3 individuals had a small FEV1 decline, and Technosphere insulin back to basics. The dosing and available strengths are 4 units, 8 units, and 12 units. So you can start with 4 units of Afrezza at each meal. You can see that if the patient was injecting 4 units, you have to start with 4 units. If it was injecting 5 to 8, you have to start with 8 units. 9 to 12, 12 units. So this is simple algorithm. Now the storage and handling, that is foil packages are available, and it is blister cards or strips will be available, may be used within 10 days, and the strips which are opened must be used within 3 days. So key steps to use Afrezza, that is the simple loading, inhaling, and removing the device. So it is very simple. So Afrezza is indicated, Technosphere insulin as a rapid acting inhaled insulin, indicated to improve glycemic control in adult patients with type 2 diabetes, and in patients with type 1 diabetes must use with a long acting insulin. That is very important. Not recommended for the treatment of diabetic ketoacidosis, not recommended in patients who smoke. Chronic lung disease are contraindication like asthma, COPD, because of acute bronchospasm may occur during the episodes of hypoglycemia, and hypersensitivity to regular human insulin or any other expient. So to conclude, the things to remember before initiating Technosphere, it is necessary to perform a detailed medical history, physical examination, and assess the FEV1 to identify potential lung disease. The FEV1 should be more than 70% of the predictive value. That is very important. Assess the FEV1 at baseline after first 6 months and annually thereafter. In patients taking Technosphere, if FEV1 declines by 20% from baseline, we have to discontinue. Now, in nutshell, the Afrezza is the only inhaled insulin approved for use in diabetes patients. Ultra long acting in mealtime insulin along with compact inhaler device, oral inhalation of regular human insulin for postprandial glycemic control. Found safe and effective in clinical trials with over 3,000 treated patients. Offers proven mealtime glucose control, prompt reduction of high blood glucose within 12 minutes. And the most common adverse effect include hypoglycemia, cough, throat pain or irritation. It is approved by Indian regulator Rediscover for adults treatment with diabetes mellitus only. At present, it is recommended for type 2 diabetes with in adult patients. So thank you. Thanks a lot for your patient hearing.
Thank you very much, Ashish. You have given the very nice speech on the newer insulin, inhaled insulin, that is Afrezza. One question is mine. Where is a smoker's cough? Smoker's cough.
Yeah.
Smokers can take this insulin or not?
No. It is contraindicated.
Not,
you should avoid it in smokers.
But he used to get the cough.
Yeah.
As usual. That is known as a smoker cough.
Yeah. So we have to avoid in patients who smoke.
And how to titrate the dose?
Titrate the dose as per the sugar reports like we do in insulin.
Like 20 unit, 24 unit, then how can you titrate?
Yeah, that is very dicey situation in this because it is available
it is not possible.
Only in 3 units. So it is very risky, but the patient who is not willing for the injectable therapy, that is very, we can use this in those patients. Thank you, sir.
Thank you. Very good speech.
Mic do na bhai, baithe reh raho.
The dose different for different cities, like for Delhi, the over polluted one, and the cities or villages which are less polluted?
Yes, very good. Because the FEV1 will be different in different cities. So in Delhi, most of the patient will be rejected for this because you have to do PFT first before starting. So maximum patients may not be falling into the category for indications. So that is a very good question. So we have to first do FEV1 test at our clinic, then only, and you have to do, take meticulous, strong history, then only you can start this. तो ये झंझट का काम है, एक लड़का पहले बिठा के रखना पड़ेगा, 2 पेज लिख के हिस्ट्री लेगा, then you can start this insulin. But let's see, all the new drugs are coming with some hitch, but we are using, first हम DPP-4 से डरते थे, now it is very commonly used. फिर हम newer insulin से डरते थे कि बहुत महंगे हैं, but due to their advantage we are using it. So let's see, like that Dr. Ashish Tiwari sir has taken in inclisiran lecture at Khajuraho. It is very costly, but it is very useful. 54% reduction in LDL is seen. So the newer drugs are having the challenges, but let's see what the future says. Thank you.
Now one question or, GDM and pregnancy.
Yeah.
Can we use?
No.
No.
Not recommended in pregnancy.
Thank you very much, sir, for the discussion. Now we request our chairperson to kindly felicitate the speaker and speaker to kindly felicitate the chairperson.
मेरा तो हो गया है, सर लोगों का करना है. जी. Thank you. आइए.
But thank you, sir, for the wonderful talk.
आइए सर, हाथ लगाइए. Thank you. आप सर को दीजिए. सर को. जा रहे हैं सर.
I request you, Dr. Ashish sir, to kindly close the day 1.
Yeah. So, 2 minutes. Wait. Close करते हैं. So, thanks a lot for the day 1 successful NDID 2025. It was the 7th International Congress. कल सबको आना है, अमेरिका से भी डॉक्टर आ रहे हैं कल, और कल के जो लेक्चर्स हैं वो बहुत ही इम्पॉर्टेंट है और इन्फॉर्मेटिव है. डॉक्टर वितुल गुप्ता सर इज़ फ्रॉम भटिंडा, ही हैज़ ट्रेवल्ड सो लॉन्ग, तो उनका टॉक है. और उसके बाद फराज है हैदराबाद से, मोहसिन, दे आर माई फ्रेंड्स, दे हैव ट्रेवल्ड फ्रॉम हैदराबाद, एंड लॉट ऑफ lectures will be there which are very interesting in your clinical practice. Dr. Jayant Panda sir will be there, and Dr. Rajiv Kovil from Mumbai is coming, and you can see the lucky draw is also there tomorrow. तो दिल थाम के बैठिए, कल सबको आना है, और lucky draw जो आप लोग कल आएंगे तो इनॉग्रेशन के समय अपन खोलेंगे, तो लेट्स एंजॉय द गिफ्ट्स आल्सो टुमारो एंड दैट MMRF स्पेशल NDID स्पेशल डॉक्स विल बी रिलीज टुमारो। तो आपके लिए बहुत सारी चीज़ें हैं, कल सबको आना है और ढेर सारे गिफ्ट पाना है। थैंक यू।
Thank you, sir. We request you kindly join us for the dinner.